Welcome.
Good evening, sir.
Yes, sir.
Good evening.
Welcome to Benchmarks.
Yeah, good evening, esteemed faculty
Hello,
members.
hello. Hi, this is star studded. Rishikesh, Nandita, Amit.
Bhaskar Pal.
Who was that?
Yes. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, The Benchmark with ISAR. And the topic is Current Concepts in Infertility Management. So it's my privilege to introduce the convener of today's webinar, Dr. Monica Sinha.
Okay, Sai.
Ma'am is the managing committee member of ISAR, Vice President of Bhopal Abhiyoy Society, West Zone Coordinator, Medical Disorders Committee, FOXY, Convener of ISAR Perfection Series, and Convener of FOXY Symbiosis Series. I welcome you, ma'am, and I hand over the secretary.
Thank you, Sai.
Tell Mitsu to mute. We can hear all your conversation. Mitsu. Yeah.
Yeah. So,
Okay, go ahead, Monica.
yes, ma'am. Good evening, respected faculties. On behalf of ISAR, we present you the benchmark series. And this is episode 9 of this webinar. And it is being directed, the program director is Dr. Sneha Bihar. And today we are talking about current concepts in infertility management on the 24th of July. And for this, I would like to present you my program director, Dr. Sneha, who is AMOX chairperson, Medical Disorders Committee, as well as been the past chairperson of FOXY Breast Committee, very active in AMOX and FOXY, ISAR, and ICOG. She is the recipient of several awards. We can see the MS Signature Award for Phenomenal Leadership, Asia GCC Award, and she is very proud of the SN Malhotra Award because it was awarded to her for her outstanding work in rural obstetrics. We welcome you, ma'am, and request you to take the program forward.
Thank you so much, Monica, for that kind introduction. A very good evening to one and all. My respects and regards to our chief guest for today's program, Dr. Rishikesh Pai, sir, and Madam Nandita Palshetkar. Guest of honor for today's program, Dr. Asha Bakshi, Dr. Bhaskar Pal, and of course our special guest, Dr. Shivani. Respected Dr. Amit Patki, sir, the president of ISAR, and Dr. Asha Bakshi, the secretary. I'm very happy to have this program and welcome all of you here on this platform. As you are aware that this is the 9th episode and we have organizing the focus program on a particular topic. We have already had one program that is to start the series with ISAR, and this is the second one officially with ISAR. We are very proud to have you as chief guest, Rishikesh sir and Nandita ma'am, and of course the faculties, Dr. Amit Patki sir, Dr. Anuradha Kar, and of course two more faculties. We have Dr. Shweta Mittal and Dr. Anu Agrawal. All of you, I welcome, and I'm sure this is going to be a very informative program and very helpful to all the attendees. I just make an humble appeal to all of you that myself, Dr. Sneha Buyar, I'm contesting for the post of Vice President FOXY from West Zone for the upcoming elections. The voting process will start from 1st to 10th August. And please do bless me and vote and support me for this venture. Thank you so much. And I would like to now welcome Dr. Rishikesh Pai, sir, and have his words of blessings. I think the lady first, Madam Nandita Palshetkar. I'm very happy to have you, Madam. Of course, you are the one of the presidents under whom I have worked, and you have mentored me so well that I am here what I am today. Madam is, of course, the past president of FOXY and past president of AMOX, and she has the whole list of awards and accolades. The organizing chair of the SCOG, now upcoming in Mumbai. And of course, she is the eminent IVF specialist with more than 28 years of experience. She's got specialization in ART and so many awards and accolades that, the time will go reading the whole list. But
Thank you.
Precious time we want to utilize listening to you, Madam. Over to you, Madam.
Thank you, Sneha. Thank you for inviting me here. ISAR is very close to my heart. And it being World IVF Day, I think you all have set off the program to celebrate IVF, celebrate embryologists, celebrate clinicians. So thank you so much for inviting me here. Dr. Rishikesh Pai, who's the chief guest, Dr. Amit Patki, who is the president of ISAR, Bhaskar Pal, a very dear friend who is another guest of honor. It's nice to see him free from a little bit free from his usual schedule. Bhaskar, it's really a pleasure to see you. Then I think there is Shivani, who is a chief guest. It was a real pleasure to see you too, Shivani. And of course, all the other friends, Monica, Sneha. Sneha, of course, is fighting the elections. All the best. Bhaskar, all the best. And Monica, all the best. I think all of you all are working hard. And I think, our organizations are so dynamic and so beautiful. There's so much fellowship. And I think the election itself makes us realize that, how people want to work for the organization. And it's really amazing because when we tell people we are working pro bono, they are absolutely flabbergasted that, the passion with which we work for the women's health and the different organizations, it is amazing. So I really wish all of you all best of luck. And on this World IVF Day, I think we are celebrating 45 years of IVF. A lot of things have changed, a lot of technologies have come in. And I mean, I'm really happy today. I'm in this field where you can actually create life. So it's a beautiful field. It's fantastic. And I think we are all lucky to be there in it. I can see a lot of people here. I think I can see Chaitanya, then I can see Mitsu, Kavita. Um, Anu is here. So thank you for inviting me here. And Rishikesh, being the ladies first, I think I got the chance before you. But thank you for honoring us by inviting us over here. So Sneha, all the best. Bhaskar, wish you very, very all the best and good luck. And of course, Monica also. Take care.
Thank you so much.
Thank you.
Thank you so much, madam, for your words of wisdom and blessings, of course. Once again, I would like to welcome Madam Padmarika Jirge as a speaker, and of course, the chairperson, Dr. Chaitanya Shambekar, Dr. Kavita Gautam, Dr. Kalyan Barmade, Dr. Anu Agrawal, Dr. Roshini from Andhra Pradesh, and Dr. Kundan Inge, Dr. Mitsu, and Dr. Praful Doshi, and Dr. Ashish Kare from Pune. So I welcome all of you once again. And with this, may we have the blessings and precious words from Dr. Rishikesh Pai, who is the chief guest for our program. All of you know, sir, such a popular personality and a very vibrant presidentship we have just witnessed. Sir is the past president of course, ISAR and Foxy, and founder medical director of Bloom IVF Group. Is the chief administrator of Foxy Manyata Project Group Society license with FICO Women's Concern Committee. And of course, all of us know that he is recently elected as the patron of the AOFOC, Association of Federation. So over to you, sir, for your words of wisdom.
Thank you, Sneha, and thank you, Monica, for calling me here. And I would like to pay my respects to our immediate past president, Dr. Nandita. Not immediate past president of Fox. Bhaskar was my very good friend. He's the vice president, and we wish him the very best. Amit Patki is our president, is our president who is there already. Sorry. Can you hear me? Then we have got I can see Dr. Chaitanya Chembekar, Dr. Kavita, Dr. Anu Agarwal, Dr. Shivani Sajdev, Dr. Roshni, Dr. Mitsu is there. And then we have got anyone I'm missing out on at present. I think I've covered more or less all of you. So as Nandita said that we are, it's a World IVF Day. We are on the eve of the World IVF Day, and I don't want to take much of your time, but I just wanted to show you one jhalak of where I am located at present. This is our AICOG, this is the Medivision office. This is how they are all working very hard. And we are just, me and Nandita and many of us have been sitting and working out on the logistics of it. Niranjan, as you know, Nandita is the chair of the AICOG. And Niranjan is the organizing secretary. I'm the scientific chair, and even Amit Patki, who is there, he's one of the joint organizing secretaries. So we are all of us working very hard for the All India, and that will be in our Geo Center where the Ambani wedding also took place. So actually, Ambani's took the third floor and the ground floor. We have taken the second and first floor also. So it's a huge responsibility. What is my biggest worry is that the workshops are fast filling up, and the hotels, the three main hotels are the Trident, the Sofitel and the Grand Hyatt, which are nearby. The rest of them, of course, you can come आराम से, ऐसा कुछ बड़ी बात नहीं है. 10 बजे भी आराम से आप आ सकते हो. तो that is not the problem. But the problem is that we may have to stop the registration, because I feel that if I have more than, if we have, me and Nandita, we feel that if you have more than 10,000 registrations, now we will not be able to handle. Just now in the H3 meeting, there were 13,000 registrations, and it was a real mess. So we will not be able to enjoy it. So my only request is that, that please register quickly. Otherwise, then we stop the computers now, then it will be difficult to enter. So I feel that all of you are very active members of the federation. So the registration needs to be very quick, because it's filling up quickly. A lot of people are saying there will be 15,000 people. We can't handle that kind. In the last AICOG in Mumbai in 2013, there were 12,000 people. But this time we may have to shut down at 10,000, because I want them to have a good experience. We want a good experience for all of you. It's not just to do a AICOG, but a very good experience, a pleasurable experience should be there. So I don't want to take much of your time. Sorry, Sneha, for talking about the All India in your forum, but wish you all three of you the very best, and over to you again. Thanks.
Thank you, sir. Thank you so much. And I think Amit sir was away from the video. I just invite you, sir, as a president of ISAR, for your precious words. Over to you, Amit sir.
Thank you very much. And at the onset, I congratulate this very unique series, the Benchmark series. I think you'll have truly set a benchmark as far as your academic content in the series is concerned. So congratulations to you, Dr. Sneha, and Dr. Monica, who's the convener. And I would like to acknowledge and pay my respects to my past residents, Dr. H.D. Pai, Dr. Nandita Palchetkar, a very dear friend, Dr. Bhaskar Pal, my secretary at ISAR, Dr. Asha Bakshi, and the special guest for today, Dr. Shivani Sachdev Gaur. I think this is a very, very educative series. I've taken part in this series. I've listened to this series before, and I give all my best wishes and support to you, Dr. Sneha, Dr. Bhaskar, and to Dr. Monica, and may all be successful in all your future endeavors.
Thank you so much, sir. Thank you especially for the association and the collaboration. Thank you for your blessing, sir. We now move on to have Dr. Bhaskar Pal, our guest of honors today. May we have your words of wisdom, Dr. Bhaskar, and definitely a very best wishes to you as well for your elections for President Foxy. Bhaskar Pal is a dear friend and of course a past chair of AICC, RCOG and IAG, past vice president of Foxy, immediate past president of IAG, and of course he's the past president of Bengal Afghani Society as well. A very thorough academician, I would say, a very gentle human being and very much helping hand for all of us. We look forward to you, Dr. Bhaskar, and over to you for your precious words.
Thank you, Sneha. At the outset, I thank you for the invitation. I think it's a great honor that I've been promoted. The last time Monica invited me on the benchmark series was as a speaker. And I can see that I have earned the promotion to become the guest of honor. And the last time when I was here as a speaker, it was a great program. And it's great to be among friends. And yes, I wish Sneha, you and all the best first. And after your and mine fate is sealed, then we'll wish all the best to Monica. But advance best wishes to Monica. And also, it's great to meet friends. And it's very interesting that I have the experienced the hospitality of several of you in recent times. Dr. Mitsu Doshi and Dr. Praful Doshi in Surat on the 6th of July, and Dr. Roshini at the El Leru, where we could make out that she was the general of that entire show. And great to meet friends like Anu and Shivani and Kavita and Chaitanya and Nandita. As I said, that Nandita, I've been seeing her after a long time. And so it's a pleasure meeting her. We, Rishikesh and Sneha and myself will keep bumping into one another because we are present almost at all the conferences. And I had the good fortune of meeting Shivani a week back and Anu a couple of weeks back. And thank you very much. It's my pleasure to be here. And I'm sure we'll have a great program.
Thank you so much, Bhaskar. Thank you. And we now move on to the special guest because Dr. Asha Bakshi is, I think, could not join because of some emergency. She has conveyed us. So we have our dear friend, Dr. Shivani Sachdevkar, such a illustrious person, a very gentle human being, I would say, loving friend. Director of SCI IVF Hospital, ex-clinical research fellow, Imperial College and Hammersmith Hospital, NHS Trust, and she's been featured in the Limca Book of Records. So we would like to, I mean, we're very happy to have you, Dr. Shivani, and we're eager to listen to your precious words.
Thank you very much, Dr. Sneha, for this warm invitation. And your benchmark series is like become a big brand. And the programs have been so good that this brand has become so famous and really people are looking forward to it. So congratulations for making this huge brand, and my very best wishes in your elections to come, and my very warm regards from Delhi to Dr. Pai, Dr. Nandita, Dr. Bhaskar Pal, Dr. Amit Patki, and Asha Bakshi ma'am. And so nice to see our wonderful colleagues here. Dr. Monica, thank you for inviting me. Dr. Mitsu and Praful, Dr. Roshni and Dr. Anu, so nice to meet you virtually here. And also, of course, we have Chaitanya here and Kavita is here. So all the delegates who have joined, happy, webinar today. And on the eve of World IVF Day, there can be nothing better than the benchmark series. Thank you.
Thank you so much, Dr. Shivani. And now with the blessings of God and, of course, blessings of all the respected seniors and guests, we now move ahead with the academic session. And for this, I hand over the forum to our convener, Dr. Monica Singh. So over to you, Monica. And without much ado, I think we should start with the academic session. Thank you so much, everyone. Thank you for gracing the program and blessing us.
Thank you. Thank you very much, Sneha ma'am, for the beautiful introductions. And I'm indeed very delighted to present before you, almost a bouquet of talks over here we have lined up for all of you. And in consultation with various colleagues, friends, and the Sneha ma'am, we have come out with the first talk, which will be Asospermia, what next? Because this is a topic which continues to baffle us. Despite whatever treatment might be formulated, we still want to listen more about Asospermia, and who better speaker than Amit Patki sir. The next speaker is Dr. Anuradha Kar, who will be deliberating on ovulation induction in IUI. Again, a topic very favorite with all juniors and seniors alike. The juniors want to learn everything about the seniors want to update the knowledge. We go on to Dr. Shweta Mittal from Delhi, who will be deliberating on oocyte cryopreservation. She calls it an elixir for youth. And that's a very interesting title she gave us. And lastly, we have the failing ovaries, always a conundrum, a management dilemma. which will be taken by Dr. Padma Rekha Jirke. So for the first session on Asospermia, what next? I invite our chairpersons. May I have the slide of Dr. Kalyan Barmade? Madam, I think sir has not joined.
Him, so we can have
Yeah.
introduction.
Can I now introduce Dr. Anu Agrawal? I'm delighted to introduce before you chairperson for first session, Dr. Anu Agrawal from Varanasi, a very accomplished academician, managing committee member of ISAR, a good friend. And she is directing Vansh Fertility and Test Tube Baby Center, as well as Ayushman Hospital. I had the privilege of visiting both her hospitals, seeing the great work she's doing. She's also the joint secretary of Varanasi Obs-Gynae Society, interested in minimal invasive fertility enhancing surgeries, as well as ART, has presented various papers in national conferences, as well as written in journals and chapters in various books. We thank you, Anu, for joining us today. And I also take keen pleasure in welcoming Dr. Roshini to our program today from Eluru. And we have already listened to how well she manages conferences and big events, academic events. So, madam, we welcome you here. She is again an accomplished academician trained in reproductive medicine and surgery, as well as andrology from the University of Miami. She's also published several research papers in journals, is working at Sri Krishna Fertility Center, Eluru, is an executive member of IFS AP chapter, Eluru OBGY Society. She's an executive member. She has organized the very successful 9th APCOG 2024 State Conference. And she's Secretary APOGS 24-25. Welcome you, ma'am. And I would like you to introduce our speakers.
Thank you so much, Monica, ma'am, for the kind introduction. Now, at this outset, I would like to thank Sneha Buyer, ma'am, for this opportunity. And I would like to introduce our speaker, Dr. Amit Patki, sir. He's a medical director, Fertility Associates, Mumbai. He's an honorable associate professor from KJ Somayya's Medical College and Hospital. Sir is a consultant at Kar, Hinduja and Surya Hospitals, Kar, Mumbai. Sir has various accolades to his credit. That is, he's a country representative aspect 2021 to 23, governing council member ICOG 2012 to 2021. And sir is a President ISAR of 2024 to 2026. Sir is a General Secretary of MSR 2018 to 2021. And Sir is a President of MOX 2014 to 2015. And also Sir has chaired West Zone RCOG conference conducted between 2015 to 2020. Sir has 35 publications in national and international journals. And Sir has authored 50 book chapters and he's the editor of 3 books. We are very lucky to have you, sir. Thank you very much. Over to you, sir.
A very good evening, and thank you very much for having me on your benchmark series. I hope I can hold that benchmark for you all in my talk. Is my slide seen?
Yes, sir. Yes, sir.
So my topic today is going to be how and why of male infertility, assessment and treatment options in Asospermia. Prior to that, I would just briefly like to touch upon the terminology that we use. So Asospermia is when there are no sperms seen in the semen sample, and more importantly, in the pellet after centrifugations on 2 separate occasions. Aspermia is the absence of seminal material after ejaculation. And ejaculation is no ejaculation even after orgasms. And retrograde ejaculation is when the major portion of the ejaculate travels back into the urinary bladder. So as I said, semen analysis alone is not sufficient to label somebody as asospermic. I think it is extremely important that we centrifugate the sample and check the pellet, because in approximately 1 to 2% of asospermic patients, we would find semen sperms in the centrifugation. It is very important that somebody who's been labeled as azoospermic undergoes a standard physical and, more important, a scrotal examination to check for both the testes, check for the size, check for the turgidity, and check to see if there is any presence of varicocele. As far as hormonal assessment is concerned, it is suffice to do their FSH, their total testosterone, TSH, LH, and prolactin as a routine testing in hormones. It is not necessary that every azoospermic patient should undergo a scrotal USG or a transrectal USG, and I'll come to that. And if somebody is doing a testicular biopsy, in addition to looking for sperms, I think it is extremely important that we send a part of the biopsy for histopathology to rule out carcinoma in situ. When you talk of azoospermia, we can broadly group them as obstructive and non-obstructive. In an obstructive azoospermia, the semen analysis will show an absence of fructose. The volume would be necessarily low. Normal testicular volume on examination. If you could also have absence of vas deferens, and a seminal vesicle obstruction or an ejaculatory duct obstruction can be ruled out only by doing a transrectal sonography. Men with obstructive azoospermia should be offered reconstructive surgery, but we have seen in our practice that most couples prefer to go for sperm retrieval with PISA. It is important that you do genetic testing for such men, and the genetic abnormalities associated with obstructive are different from non-obstructive azoospermia. And the technique for sperm retrieval is PISA as against TISA, which is in non-obstructive cases. So when we talk of non-obstructive azoospermia, the first thing is that there is presence of fructose in the seminal sample. The seminal volume is normal because there is no obstruction to the seminal vesicles or the ejaculatory duct. On examination, if the person has reached testicular failure or has high FSH, you will find that the testes are small. You will get flat epididymis. The pH would be alkaline. And on blood test, you would get an elevated FSH with near normal or normal testosterone and estradiol levels. And the way to obtain sperms would be to do TISA, micro-TISA, or TISA. It is important to counsel both the groups, the obstructive and the non-obstructive. But in most cases, in the obstructive, you get plenty of sperms in PISA samples. But in the non-obstructive cases, especially when the AFSH is more than 15, there is risk of not finding sperms in the TISA or in the micro-TISA. And hence the couple should be counseled for the potential use of donor spermatozoas if no sperms are identified in testicular tissues. So when we do a testicular biopsy, we don't advise a testicular biopsy prior to treatment, but in cases where it is done, the most advanced spermatogenic pattern as opposed to the predominant pattern seems to affect the results of sperm retrieval. So the most advanced is that if men who have at least one area of hypospermatogenesis present on the biopsy, the chances of getting sperm is as high as 80%. For men with maturation arrest, sperms are retrieved in almost 40% of such men. And in men where there is entire diagnostic biopsy of Sertoli cell syndrome, sperms are obtained in almost 20 to 25% of patients. So it is very important that you counsel the patient accordingly. Quite often, we resort to doing a testicular biopsy, especially when the counts are very, very low, or when the sperm DFI is extremely high and you have tried to treat their lifestyles, their comorbidities, put them on antioxidants. Despite all treatment, if you find that the sperm DFI is high, then you can counsel the patient for using TISA samples, because testicular sperms which are retrieved in patients with cryptospermia have poor fertilizations. But men with partial obstruction or with high DFI, we could use the sperms which are retrieved in the TISA samples, and they are known to give us better fertilization rates, better blastocyst rate, and better implantation and pregnancy rates. However, we should not resort to every patient with low sperms with testicular biopsies, because we still are yet to see for any epigenetic or genetic changes that may occur in such children who are born with testicular sperms. Scrotal ultrasound should be strongly considered for patients with history of cryptorchidism or prior germ cell tumors, or in men who have unexplained abnormalities on testicular examination. Routine scrotal ultrasound for subclinical varicocele is not recommended. I think varicocele should be diagnosed only on physical examination. And if the testicular volume is normal, if the testicular turgidity is normal, only repair of such varicoceles will give you improvement in the sperm parameters or improvement in the fertility. When you do the blood test for men, you can have a scenario of hypogonadotrophic hypogonadism, which means both the LH and FSH are reduced less than 1. The differential diagnosis being Kallmann syndrome, pituitary tumors, anabolic steroids, which is very important in this day and age when you see very young men who are buffed up, beefed up. You must ask history for testosterone or anabolic steroids. Morbid obesity also leads to very decreased levels of LH, FSH, hemochromatosis, and sometimes you are unable to find the cause. But when the FSH ALH is extremely low, you can counsel the patient for a minimum of 90 days of HMG 150 and HCG 1500 given bi-weekly. It is important that you counsel because the expense is going to be running in a few lakhs, and the effect is seen only if you give it for a minimum of 90 days. When you do the total testosterone, you can land up with men with low testosterone and low testosterone estradiol ratios, and such men can be only routinely treated with anastrozole 1 milligram per day. For men who have been diagnosed with Klinefelter syndrome, response is better using testolactone 50 to 100 milligrams per day. But routine use of testosterone or anti-estrogenic drugs like clomiphene should be avoided only if you have very high estradiol levels or low testosterone levels. Can you use testosterone or anti-estrogenic drug? If the prolactin levels are high, you do the same treatment that we do for women, treating them with dopamine agonist. In men with idiopathic oligoasthenoteratospermias, there is no evidence or effectiveness of treating them with androgens, HMG, HCG, anti-estrogen, prolactin inhibitors, or steroids. When you have azoospermic men with hypergonadotrophic hypogonadism, which means the LH, FSH are both raised, you have to have a differential diagnosis of testicular dysgenesis or testicular failures, Klinefelter syndrome, castrations, cytotoxic medicines, or past history of radiation. It was in 1992 that Palmero et al. Delivered the world's first test baby conceived with ICSI. We know that ICSI is a highly effective therapeutic intervention, particularly for severe male factor infertility, and in my opinion, has truly revolutionized the management of male infertility. But there are concerns with ICSI, concerns are of transgenerational transmission of genetic defects to the offsprings, causing gametogenic failures. And why is that? Because ICSI bypasses the effective biologic mechanism of sperm selection, which happens in routine IVF. ICSI was never applied as extensive research trials in mammals. It was accidentally discovered by one of the embryologists when they tried to play around with sperm and eggs. And the human experience with ICSI is the experimental record. And as I said, if it has the potential to negatively impact the genetic composition of the human population if we go on using ICSI. So it's very important that we do genetic testing, the routine karyotype, and the Y microdeletion as two separate tests, because 13 to 15% of men with Asospermia will have genetic abnormalities. 5 to 7% of men with count less than 5 million will have genetic abnormalities. And these errors are often seen in normal sperms also. So when you get poor fertilizations, poor implantation, despite having normal semen counts, I think it is important to do their sperm DFI, one, and to also do their karyotype to rule out any karyotypic abnormalities. When you have bilateral congenital absence of vas deferens, you must do the cystic fibrosis gene mutation, which is now available in our country. Delta 508 is the most common Caucasian mutation. We still do not know which mutation is most common in the Asian populations. When you have men with Asospermia or severe oligospermia, it's important to do their karyotype and Y microdeletion. And when you have very high FSH-LH, it is important to rule out any structural defects or aneuploidies like Klinefelter syndrome. As I said, 13 to 15% of azoospermic men and 5% of men with severe oligospermic have abnormal karyotypes. We now know that there are certain meiotic disturbances that are found in the spermatogenic cells itself, and that we do fish on the sperms to rule out any of these abnormalities. We know that first trimester losses are maximum with sperms obtained from the testes, and 2.2% of children born with from severe male factor infertility can have major congenital malformations. And I think it is extremely important to discuss and counsel the couple. What is this Y microdeletion? It is important to check for certain AZFA, B, and C regions on the Y chromosome, because these are the regions that code for spermatogenesis. We know that 98% of the Y chromosome is actually junk DNA, which means it is repetitive sequences which doesn't code for anything. But the 2% of the genetic material on the Y chromosome is all that makes a difference between a person with normal spermatogenesis and somebody with Asospermia. So these AZF A, B, and C regions are located on zone 5 and 6 of the Q arm on the Y chromosomes. There are other 15 novel genes which are identified on Y chromosomes. There is also the DFFRY, the RBM, and the DAS genes which are associated with male infertility. However, it is important to say that even if you look for Y microdeletions, we should be fine. So if there is AZFA deletion, it is lack of germ cells or Sertoli cell only syndrome. So your chance of getting sperms on TISA are low. If it is AZFB, it is spermatogenic arrest, and maybe you could get good sperms. AZFC is maturation arrest of post-meiotic sperms. So approximately 50% of men with deletions involving AZFC will have sperm present in the ejaculate. For AZFB, it is very low chance of getting sperms, and AZFA are associated with Sertoli cell-only syndrome. However, newer research indicates that there is no strict watertight correlation between the severity of the spermatogenic defect and the location and extent of YQ deletions. And hence, there are other genes outside this AAZF regions which can modulate or have different effects on the azoospermia. What is important is that these people who have got Y microdeletion would pass it to their sons who are born. And it is important to counsel the couple that if there are daughters born with treatment, fortunately, the Y microdeletion is not passed. But if there are sons born, this Y microdeletion will be passed on to the sons. But the good news is that these men, as young adults or adolescents, do make sperms in the initial second and third decade of life. And the sperm and this activation of the Y microdeletion happens only later on. So it is important that you can ask such young adolescent boys or young adults to freeze their sperms, because when the third decade of life sets in, these genes get activated and the azoospermia sets in. So you can use these sperms which are freeze later on. This is just to show you how the PCR works. It's called as a multiplex PCR, where you find Y microdeletions. Even after counseling, 96% of couples in this study in 1998 chose to use their own sperms because they knew that science had lots to offer and they were not really worried of Y microdeletion because it doesn't cause any other health issues. We have also done fish on sperms on the ejaculate, and we have found that men who have got severe OAT can have sperms which have got disomy of 18. Sperms generally should be haploid. So when they have two chromosomes of the same number, we know that they can be a problem. So this is a picture to show you disomy 18, the XY chromosome, or the sperm having two Y chromosomes. Cystic fibrosis is an autosomal recessive disorder. It is due to mutations in the CFTR gene. These individuals have delayed puberty, have generally azoospermia, and have got infertility. And on examination, there is congenital bilateral absence of vas. So if you examine the male and you find that there is absence of vas, it is very important to look for cystic fibrosis. And if the cystic fibrosis is present in the male, it is very important to rule out that the cystic fibrosis mutation is not present in the female, because you can have an individual affected with cystic fibrosis. PCR technique on blastomeres are done. So in azoospermia, genetic testing becomes an integral part of the patient assessment, treatment planning. The package should be karyotyped for all of them. Fish only if you have the facilities to offer. Y microdeletions in azoospermic and severe OAT, and cystic fibrosis in patients with congenital bilateral absence. I think I would like to stress on testicular cancers. We know males with infertility were 3 times more likely to develop testicular cancers. And hence it is important that if you ever take a biopsy, you should send part of it for histopathology to rule out testicular cancers or carcinoma in situ. We know that almost 2% of biopsies were tested positive in this paper in Human Reproduction of 2007. And I'm sure the male partner will thank you enough, even if you don't give them a baby, but you pick up testicular cancers and you can treat them. What is also important is that follow-up after ART treatment. In cases of hypogonadism, and once they have finished their fertility treatment, androgen replacement should be offered to these men. In men with borderline testosterone levels or LH levels need to be reassessed every 1 to 2 years, and you can supplement them. And testicular microlithiasis, if you find that there is multiple calcifications in the testes, I think a testicular biopsy should be considered in such men to rule out carcinoma in situ. I thank you for a patient hearing, and I'm very happy to answer any questions.
Excellent presentation, sir. What is your experience about tuberculosis and azoospermia in Indian scenario?
Yeah, so if you have, they generally come with obstructive azoospermia. It is very difficult to do vaso-vessel anastomosis because the vas is completely destroyed. But if their FSH levels are less than 15, most often you would manage to get sperms from the TISA or even micro TISA.
Thank you so much, sir.
So it
So,
was a wonderful.
yes, please.
Yeah, please. Should I?
Yes, please.
So it was definitely it was a benchmark lecture with so many take-home messages. And one thing which I'll change in my practice after this lecture, I'll send histopathology examination also after doing TISA. Am I?
Absolutely right. I think it is very important to examine the male. I always say just don't go by the semen report. I think it is very important that you examine, because once you know that the testes is normal size, it is turgid, these testes should give us sperms. On the other hand, if the testes is flat, soft, then treatment of these varicocele will not give you any encouraging results.
Dr. Kalyan, regarding your question of testis,
To
box and male, yes. We did TISA in one of our patient, and we could retrieve few motile sperms, and let's see what happens. After giving ATT, we tried TISA on him.
Yeah, thank you.
I think there is one question from Dan Bhagyam whether you should do open or needle biopsy. I think needle biopsy is the first thing that you should be doing. If you don't get any sperms on that, then it would be prudent to do an open biopsy, but then you should have the equipment basically a microscope, or you should have your loops to have a magnification, because only then will you be able to see the tubulars and the tubules, and then maybe aspirate from a turgid tubule.
You mean to say micro TISA, sir?
Correct. So micro TISA should not be done as a first step. I think you should be doing a needle biopsy or an open biopsy. And micro TISA, you need the full equipment, you need a microscope, or you need at least the loops for your eyes to have a magnified image, and the patients to sit for 2 hours at least. I think Dr. Roshni is there, who's trained with Dr. Ranjit. Maybe we can have our opinions.
Yes, Dr. Roshni.
Sir, yes, sir. Actually, micro TISA, definitely it will be a like 2 to 3 hours procedure, sir, as you have rightly said. Even when I was getting trained under Dr. Ranjit, sir, he used to tell, sir, micro TISA needs a lot of patience. You have to check all the tubules and extract the sperms, and then you can give it to the fertility specialist. And thank you very much, sir. That was an excellent lecture. And it was actually definitely it is suiting to the benchmark series, sir, like rightly told by Dr. Anu madam. Thank you very much, sir.
Thank you very much.
Yes, thank you, Amit sir. That was excellent deliberation as always from your side. We are very happy to have you as the opening batsman, and the benchmark has really, the bar has really raised very high. I think there's one question, sir, for you. If there is a Y chromosome microdeletion while planning IVF, what all things should be concealed?
So which zone, whether it is A, B, or C, that will give you the prognosis of what you would get on TISA or micro TISA. So the best prognosis comes in B. But it is important to know, as I said, which of the AZF region is deleted. And if the karyotype is normal, you can often have karyotype and Y microdeletion together in some of them. But if your Y microdeletion is absent, then I think you should be reassured that you can go ahead and do a TISA and you would get sperms in such patients. If your FSH is normal, I go by the FSH and the physical examination if I have to counsel the patient.
Sir, I would like to ask you a question. Sir, how often do you find CFTR mutation in Indian population?
Yeah, so the problem is that the Delta 508 is the most common mutation, but it is for Caucasians. We sadly do not have which is the most common, but now there are labs which are doing all the 18 mutations. Previously, they used to do only 5 mutations, and we weren't sure if those mutations are what is for Asians. But now if you have a lab which does all the 18 mutations, then I think your pickup rate for CTA for your will be higher. But if you do only Delta 508, it is Caucasians, and we can't replicate that to our population because unfortunately we don't know which is the most common yet.
Thank you, sir.
Sir, may I ask one question, sir?
Yeah, Dr. Anu, I think, do you have some comments?
Yeah.
Sir, what is your take-home note on varicocele-induced azoospermia, sir?
Yeah, so varicoceles which are physically diagnosed, not on ultrasound, where the testicular volume is normal, the testes are turgid, and the FSH is normal, such varicocele, you'll be able to downgrade the treatment. So even in azoospermic men, now you do varicocele because you can downgrade the treatment. So if you're going to do a TISA, maybe you'll get sperms in the ejaculate. If you have to do an ICSI, maybe you'll get away doing IVF. If you have to do IVF, you may get away doing IUI. So the choice of the patient and choosing the patient is extremely important. If you randomly offer varicocelectomy to all, especially to men where the testicular volume is small or the testes are soft, flat, I don't think you'll get any success. So it is very important which patient you choose. So we do advocate varicocele had got a bad name in the middle because it was indiscriminately done. But now there are good papers and research to show that you can downgrade the treatment if you choose the right patient.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you once again for the very excellent lecture. And of course, thank you so much.
Thank you, Sneha, for having me. And best of luck to you. You are the most eligible candidate. I think you have proved yourself in your other positions, and my best wishes to you.
Thank you, sir. Thank you so much. That means a lot to me. Thank you so much once again. Thank you, Dr. Kalyan, Dr. Roshni, Dr. Anu, for chairing the session and your excellent inputs. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Monica.
All the best, madam.
Thank you so much. Thank you.
Best
dear.
of luck, madam.
Thank you, dear.
We look forward to see you.
Thank you, my dear. With your wholehearted support, yes, it's going to happen. Thank you so much.
Thank you, chairpersons, first session. And now we move on to session number 2, that is the talk number 2, and it is by Dr. Anuradha Kar, who will be deliberating on ovulation induction and its intricacies in IUI. For her talk, I invite chairpersons, Dr. Chaitanya Shembekar and Dr. Kavita Gautam. I would like to introduce the lady first. Dr. Kavita Gautam, I'm delighted to introduce her from Bloom Life Hospital. She's Academic Joint Secretary, TAPISAR 2024, and a senior consultant dealing with subfertility, fertility-enhancing laparoscopic surgeries, and high-risk obstetrics. She has been the past South Zone Coordinator of Foxy Infertility and Sexual Medicine Committee and Global Healthcare Leadership Alumni from Harvard. She holds a diploma in reproductive medicine from Kiel, Germany, She's received advanced training in ART from Singapore, sonography from Nagoris Institute, as well as Mediscan Chennai. She is the director of Bloom Life Hospital and is a keen academician seen at several conferences. A member of ESHRE ASRM, has authored books in obs and gynae, authored chapters in gynae books and fertility books. The recipient of J.L. Javeri Award, and also been awarded the Youth Icon Award of Healthcare and IVF Treatment in 2019. Welcome, Dr. Kavita Gautam. And now I would like to invite Dr. Chaitanya Shembikar for chairing talk 2. Dr. Chaitanya Shembikar is a brilliant IVF specialist, obstetrician gynecologist from the city of Oranges, Nagpur. He is a very, very hardworking gynecologist. He is not available morning 7 a.m. onwards in OT every day, and heading Omega Hospital, the 100-bedded single specialty state-of-art hospital in Nagpur. And he's also the past president of Nagpur OBGYN Society, president of Om Charitable Institution, and vice president Sevankur. He is a member of the PCPNDT committee of Nagpur, so must be helping several of his colleagues. Member of advisory board of ART unit at AIMS Nagpur, chairman of Infertility committee of AIMS.
Chaitanya is not able to. He has just left for the emergency. He's just
Okay, so I think now Dr. Kavita can introduce our speaker.
Please go.
Thank you, Sneha ma'am and Dr. Monica Singh for inviting me here and to be a part of Benchmark series. This topic on ovulation induction and IUI, I think it's a very important topic for all the young gynecologists who are interested in learning about fertility. Now I invite Dr. Anuradha Kar, my friend, director at Nurture Specialty Women's Clinic and Fertility Center. She's done a fellowship in reproductive medicine, RGUHS College, Bangalore, and MBBS at King's George Medical College, Lucknow, and infertility and IVF specialist, consultant obstetrician gynecologist, executive committee, Karnataka chapter of ISAR, joint secretary, HSR, Doctor Association. She has publications in Indian Journal of Surgery. Over to you, Dr. Anuradha Kar.
Good evening, everyone. I would like to thank Dr. Sneha Buyar and all the best for her elections. I think she's a very deserving candidate. Thank you, Dr. Monica, for giving me this opportunity to talk here. And thank you, Dr. Amit Patke and all the team ISAR who are involved in this today's webinar. So I am going to talk about a very important topic today. Can I share my screen now?
Yes, please.
Yes, you can.
Is it visible?
Not yet, Anu. Not yet.
Oh,
It's not shared.
one second. One second. There's some.
You can see that screen, share screen icon, green colored share screen. I think, yeah, got
Yeah.
it. Yeah,
Okay.
yeah. Thank
Okay, now it's fine. Okay. So ovulation induction in IUI cycles. I think this is very important to understand why we are doing IUI, because the natural conception rates per cycle decline as the number of failed attempts at conception increases. Now, if we have younger couples who have not previously tried and have not conceived, pregnancy rate is 30% in the first 2 months, and it will decline to 8% after 6 months and 4% after 9 to 12 months. Also, female age, we all know, has important impact on the fecundity rates. And definitely, both live birth rates of natural and treatment-related cycles, it decreases after 35 years. Now, why do we do IUI? IUI because the It is a less invasive, less expensive, and compared to IVF, it has a lower multiple delivery rate. That is 10.4 versus 20%. And the pregnancy rate per cycle, if it is done properly, could be compared to IVF with minimal ovarian stimulation. Now, we have all of us, we have been doing IUI for decades now. So evidence does support ovulation induction plus IUI over a natural cycle, though there are exceptions. And the likelihood of pregnancy increases with IUI over timed intercourse. And if chosen properly and executed scientifically, it can decrease the burden of IVF ICSI by 25%. So a well-timed single IUI will work almost equal or better to two IUIs. Now, quick reckoner for indications. Yes, unexplained infertility, mild male factor, mild moderate endometriosis, ovulatory, anovulatory infertility, Asospermia, where we do donor IUI, immunological illnesses, serodiscordant HIV, couples, single women, and erectile dysfunctions, hypospadias, cervical factors, and problematic polycystic ovarian syndromes. So prerequisite is that at least one patent tube should be there, and the total motile sperm count should be around 5 million per ml. We have these type of IUI cycles. We have natural IUI cycle, modified natural. Then we have oral ovulations plus IUI, where we do not use gonadotropin. Oral ovulation plus gonadotropin plus IUI, which is most commonly done by all of us. Gonadotropin IUI and gonadotropin with ANTAC, though it is not very done frequently, but yeah, for timing or avoiding a weekend, or if there has been a premature rupture of a follicle in the previous cycle. We have IUI, donor IUI cycles where the husband is asospermic. So let's directly go to natural cycle, how we do it. So day 2, day 3, we call them for a basic ultrasound where we check if is there any cyst or how is the endometrial lining. And then we just track this follicle, call them on, say, depends on the cycle length. Generally, we can call them between around 8 to 10 days and then follow that follicle. Once it's reached 18 mm, you can just monitor that follicle for just a natural rupture, which ruptures naturally, physiological rupture, or you even the LH surge kits. See, if the patient cannot come so frequently, you can't monitor a patient morning, evening. So you can give the LH kit and they can see the LH surge, and 24 hours after that LH surge, the IUI can be done. But even in natural cycle, to time the IUI very well, HCG can be used, 5000 IU. So the ideal candidates for natural cycle, as I already mentioned, is donor IUI in an ovulatory female, young female without any abnormality. It is not recommended for other indication like unexplained or endometriosis. Even a patient of vaginismus, a young patient, we can do a natural cycle if husband's semen analysis is is fine. It's okay for an IUI. So LH surge monitoring, what is the advantage? It is more physiological, but it does not give us that weekend free for all of us or for the patient. Whereas the ultrasound monitoring, it's a more structured monitoring, and the timing of IUI can be planned very well. Now, this is a paper where it was concluded that the outcomes of therapeutic donor insemination natural cycle HCG versus urinary LH monitoring. They did urinary LH monitoring, and they were comparable between these methods. So overall, home monitoring of endogenous LH surge with kits is physiological, and it can be used especially by our doctors, our gynecologists who are practicing infertility in semi-urban rural areas where patient comes 100 kilometers to them to do this ultrasound. So there we can use the LH kit if we teach them properly, or HCG administration can also be used. Now, controlled ovarian stimulation with intrauterine insemination is more successful after HCG administration than LH surge. Now, this was one paper. They said, no, compared to this thing, the recombinant HCG, the benefit is amplified. So in recombinant FSH medicated cycles. Now, this was one paper which I thought I will tell. Now we go on to the IUI with medicines, which we do with ovulogens or ovulogen plus gonadotropin or gonadotropin. Now, little bit we have to understand about the ovulation and luteal phase. I'll not go into detail. After we have to understand, this is important to know for the timing of the IUI. So after the onset of LH surge, the ovulation will occur 36 hours after the ovulation, the onset of LH surge. But when we pick it up on the LH kit, it will peak, the LH surge peaks in 24 hours. That's where the LH surge is picked by the kit. And after 12 hours, the ovulation will occur. So if you give HCG injection, ovulation, the IUI can be timed 36 hours later, or the peak LH surge, you can do it in around 12 hours. So FSH threshold and FSH window. So this is little bit, we go into the luteofollicular transition. Now, this is important to understand for the ovulation induction, especially in polycystic ovarian patients, PCOS patients, where we can have multifollicular response or no response at all initially. And when we increase the medicine or the injectables, the gonadotropin, suddenly the follicles grow too much. So FSH levels increase in the luteofollicular transition. And what it does, this FSH level, it will decrease, it will prevent the antral follicle cohort from undergoing atresia. And further FSH increase, once the FSH increases further, it reaches a particular concentration to a distinct level. And that is around 10 to 30% rise above the threshold, which is enough for a follicular development. And this limited duration of elevated FSH levels above the threshold for single dominant follicle, this is our FSH window. So this is what I have, in PCOS. If we do not reach that FSH threshold, there may be no response, or if we overshoot that FSH threshold, too many follicles may develop and we may have to cancel our IUI cycle. So what are the principles of ovulation induction? We should achieve the pregnancy in the shortest time, avoid OHSS, avoid multiple pregnancy. Now, optimal controlled stimulation, ovarian hyperstimulation and IO, or what we called as ovulation induction also. The increased number of oocytes, we should have around 1 to 3 follicles between 18 to 22 mm. Triple layer of endometrium more than 7 mm. IUI day generally should fall between 13 to 16th day. And correction of subtle ovarian luteal phase dysfunction should also be done. Now the protocols, oral ovulogens like letrozole and clomiphene, these are age-old drugs which are used. Combined is either CC gonadotropin or letrozole gonadotropin and only gonadotropin. And now let's compare the clinical pregnancy rate and the live birth rate. Gonadotropin plus IUI, around 35% clinical pregnancy rate and 32% live birth rate. So if you compare them with CC-IUI, it is 28% and 23%, and letrozole plus IUI is 22 to 18. So here we can get to know that gonadotropin cycles give us the best results. What are the factors which influence the response of COH? How do you decide? Age. Age is very important. Older age group where the AMH levels drop, definitely the response will be lesser. Obese patients will have lesser response. Their genetic, race, everything can influence the response, the cause, the duration of fertility, the health of the patient, the nutrition. So basic workup, we should not go into detail. We would have already done all that. But yes, AFC and AMH and tubal patency, either by SSG, HSG, or if they have done laparohistoscopy, that is a basic workup. And generally, patients we receive, they have had earlier monitorings outside, either a natural or with induction. So it becomes easy for us to assess how to do this ovulation stimulation, how to do the ovulation induction. Now we call the patient. How do we do it? We call the patient on day 2, do a TVS, rule out any residual follicle or persistent corpus luteum. Look at other cysts like endometriosis and all endometriotic cysts. Look at the previous treatment history, any IUI failures. Counseling is very important for the patient regarding the outcome. We should not paint very rosy pictures. We should tell them the accurate pregnancy rates and about the procedure, because some patients are very scared to undergo any procedure, and no false hopes to be given. Coming to the clomiphene citrate, it is a SERM. We all know that tissue-specific antagonist agonist in action. Long life is 5 to 7 days. Multifollicular development is a problem with this, which does not happen with letrozole generally. And poor cervical mucus, endometrial thickness. Endometrial thickness can be affected. It can be thin endometrium. CC resistance and failure can occur in 15 to 40% of the patient. Chances of multiple gestation and OHS is more. Decreased uterine blood flow also has been seen in some cases. Letrozole, it's a third generation aromatase inhibitor, shorter half-life, 45 hours, monofollicular development generally, and it does not affect the endometrium cervical mucus, which is good for the patient to conceive. Decreases the total required dose of gonadotropin. Chance of multiple pregnancy is lesser. The CPR and live birth rate in PCOS is more with letrozole. And now CC mechanism of action, I will not go too much detail, but yes, it does block the E2 receptor in the hypothalamus, and more pouring of FSH and LH from anterior pituitary due to increased response of GnRH, increased follicular development, increased circulating estrogen, positive feedback on surge center, and LH surge and ovulation occurs. Clomiphene, again, this is the same what I have already mentioned, but I want to mention that it can it can have effect on the endometrium, the vagina, the cervix. So here we have to really monitor this patient for the endometrial thickness. Dosage, you can start any day from day 2 to day 5. Minimum starting dose 50 mg and maximum 150 mg. Majority respond to 100 mg per day. But if patient earlier has had 50 mg and no response, you can make it 100 mg and in the next cycle, and then definitely they'll get a response. High ovulation rate around 60 to 85%, which is good. Pregnancy rate 30 to 40%. Chances of getting pregnant are maximum in first 3 cycles. We have to understand. Don't keep on giving for this CC if they do not get pregnant fast. Now, CC resistance, CC failure, failure to ovulate after 150 mg for 5 days per cycle for at least 3 cycles. That means the patient is resistant to the clomiphene. You should try with some other medicines like letrozole or gonadotropins. 15 to 40% in PCOS can have this resistance, obese, insulin resistant, and hyperandrogenic, because all these things happen in the PCOS patient. Failure is that the ovulation occurs, but they do not get pregnant after 6 cycles of trying. And it could be because thin endometrium or any luteal phase defects. So that if you take care, maybe the failure ones can conceive. So letrozole mechanisms, I'll not go into detail. It's an aromatase enzyme inhibitor, and it blocks the feedback sent to the brain, blocks the estrogen production, and hence aromatase and enzyme inhibition occurs, and follicular development and ovulation occurs. I think we all know how it acts. So this is the graph if you want to, have a look how it affects. Yes, it does affect at the ovarian level. So yeah, letrozole blocks basically the conversion of androstenone to estrogen and temporary accumulation of intraovarian androgens, sorry, and increase follicular sensitivity to improves the follicular sensitivity to FSH. It is a safer, better alternative to CC in OI protocol for patients of anovulatory PCOS. It can be considered first line of treatment of ovulation induction in PCOS. Letrozole 2.5 mg now flow chart. This is very important because I am going to tell about step up and extended letrozole therapy. If you give 2.5 OD you've given in the previous cycle, you can make it 2.5 BD. If there is no response, you can use a step up protocol wherein from day 2 you give 1 tablet and every day you increase 1 tablet. So 1, 2, 3, 4 tablets and you give HCG trigger at 20 ml. Extended protocols, you start and you give till the lead follicle reaches around 20 mm and then you give the trigger. Now, gonadotropins, how to do IUI with help of gonadotropins. HMG preparations are there which have equal FSH, LH, and we have urinary, highly purified. FSH preparation, we have only FSH and there is varying degree of purity. Like urinary is less pure, highly purified are there, but recombinant is the most pure. Now, if we compare HMG with recombinant FSH, HMG is cost effective, recombinant expensive, response is unpredictable. Response is unpredictable in HMG, predictable response in recombinant. Sorry, 1 second. Yeah, sorry. And there is, in HMG, it's difficult to manipulate the dosage, very easy to manipulate dosage in recombinants. So which drug should be used for stimulation? So gonadotropin, so it has been seen that there's no difference in live birth and OHSS rates. And HMG and FSH, highly purified and recombinant. These, if we use, we don't have any much difference in the live birth and the OHSS rates. Now, how do we start this? There's something called a Sono scoring system, wherein we have a score of, it's based on age, BMI, AFC, ovarian volume, stromal resistance index, and stromal RI, and stromal PSV. Now, Sono scoring system, yeah. So if the score comes to 25, the dosage to start gonadotropin is 25. If the score is between 21 to 24, 37.5, 16 to 20, 75, 11 to 15, 112, and 6 to 10, 150 IUI, you can start. So if the Sono scoring system is less, the gonadotropin dose has to be given is more. So increment of dosage, if score is less than 10, 75 IU, you can increase on day 5. If the score is 10 to 20, 75 units on day 7. Score 20 to 25, you can increase the dose by 37.5 on day 10. So, and if the score is more than 20, you can give 37.5, you can increase on day 40. So these are the regimens now. Yeah. So what is the difficulty of gonadotropin and IUI? Yes, definitely affordability, because when you add gonadotropin, the cost increases. Frequent visits to the clinic. No response. Yes, it can happen. Premature LH surge and premature luteinization is more with gonadotropins. OHSS is more. Multiple pregnancies are more. The major rationale behind the clomiphene and gonadotropin combination is just that it reduces the cost of the treatment. And but if we should not be under this impression that gonadotropin will by adding it does not increase it does not reduce the estrogenic anti-estrogenic actions of clomiphene. And response can sometimes be excessive, and as a beginner of infertility practice, we can avoid gonadotropins, do simple cycles with ovulations, and maybe add 1 or 2 shots on day 5, or give clomiphene for 5 days, and on day 6 add a shot, say 75 IU or 150 IU, and then do your IUI. Now gonadotropins are started. Now these are the regimens how we do ovulation plus gonadotropin cycle. Now gonadotropin, there is one way of doing it, that you give the clomiphene for 5 days and start gonadotropin on the first day of the last dose of clomiphene. And follicular recruitment is carried out by clomiphene alone. Sonography is done after the last dose of clomiphene to see for the follicular development. So this is step-up conjunctional regimen, and letrozole 5 mg or CC 5 mg, and on 3rd day, 4th day, 5th day, 6th day, 7 days, FSH 75 is given, and HCG ultrasound monitoring is done, and HCG triggered at 18 to 20 millimeter follicle size. Now there is something called a step-up sequential regimen, where you give a day 2 to days for 5 days, day 2 onwards, either CC 50 mg or letrozole. And once the last dose of these ovulations is over, you give the gonadotropin shot on day 6. Depending on day 6, you'll do an ultrasound, and then you assess whether she needs further doses on day 7 or day 8 also. And USG monitoring is a must. Whenever we are doing IUI, I would say ultrasound monitoring is important, and HCG trigger, and especially ultrasound monitoring to avoid OHSS when you're using gonadotropins. HCG's trigger is given at 18 to 20 millimeter. Now, this is use of letrozole with FSH. See what was done. It was, this is in hemoreproduction, they did this study. And what they, what the outcome came is gonadotropin, either alone or with combination of CC, gives a higher CP, clinical pregnancy rate, and lower abortion rate following IUI. But it does increase the multiple pregnancy rate. And now in pure gonadotropin cycles, the convention protocol is up to 5th day, 75 IU we give for 5 days. And depending on the response, you can increase after 5th day, you can double the dose to 150. 10 days, if you don't have response, you can make it 225. And then you can trigger once the follicle size reaches between around 18 millimeter. Step down protocol, what is done is when you give FSH and or HMG 150, and then and then if there is once you give it for 5 to 6 days, you decrease it to 112 for 3 days, and then further decrease by 75 till HCG administration. In gonadotropin cycles, it is better that we trigger these follicles around 18 millimeter, because there are more chances of premature rupture in such patients. So CC plus gonadotropin versus gonadotropin. What happens here? Now CC gonadotropin are cost effective. Only gonadotropin is expensive. Response is unpredictable. Predictable response, difficult to manipulate dosage. Easy manipulating dosage with gonadotropin. Thin endometrium CC can lead to, but endometrium is not affected by gonadotropin. Beginners also can, beginners can use ovulogens initially and then add gonadotropins. So you have to be very careful in monitoring these cycles. If the follicles are more than 3, that IUI cycle, you should not go ahead, you should cancel that cycle. Now, special cases like hypothalamic amenorrhea patients, they will not respond to clomiphene and letrozole. Here you have to give gonadotropin preparations of HMG, that is both FSH-LH activity, and then only it will stimulate these ovaries. Now in PCOS, which is high responders, ovulation induction may be induced, can be induced without withdrawal bleed, but pregnancy has to be, pregnancy has to be excluded. And the recommended approach is first dose finding cycle is to begin with a low dose gonadotropin, increasing in small increments after 7 days, if no follicle more than 10 mm has developed. In subsequent cycles, treatment generally brings that threshold at the threshold of the response previously determined. So if they've done some previous cycles, there you can have an idea. Although 7 to 12 total days of treatment is typical in IUI, here longer duration of treatment in PCOS can, because the response could be slow or no response, then you have to increase the dose, so the cycle can be longer. And once mature follicle has developed, exogenous HCG is administered to stimulate the ovulation. Now, in low AMH and low AFC, we have to remember that we should start at least with 150 IUML, because there we are not worried about OHSS, but yeah, low AMH, low responders may not even respond to 150, so you may have to increase these dosages. When to cancel cycle? Yes, of course, if we have done everything, you have given everything, you have increased the dosage accordingly, you've reached say 300 IU or even 450 IU, and there is no recruitment, there's no need to continue the cycle. You can next time improvise your ovulation induction or stimulation technique. And or if more than 3 follicles or E2 more than 1800, if this develops, then there is a chance of multiple pregnancy. So you have to avoid IUI in such cases, or you have to talk to the patient. Like if there are 3 follicles, even 2 follicles, you have to counsel patient while you do scan before trigger. When you are counseling for IUIC, you have 2 follicles or 3 follicles, there's a chance of multiple pregnancy, and which can be dangerous, which can lead to premature labor, PIH and all. There you can counsel. If she says, no, doctor, I want to do with 3 follicles, I'll take a chance in multiple pregnancy, you take in writing, take consent of the couple, and then you can go. But if there are more than 4 follicles on each side with E2 more than 3000, it is better to cancel, because they can develop OHSS. And iatrogenic OHSS in IUI is a big no. We should not, OHSS should not be, because we can't do anything here. In IVF, if there is multiple follicles developed, E2 is more, what we can do is we can pick up those follicles, make the embryos, and we can freeze them and not transfer. But in IUI here, what we can do is not do an IUI. And even tell the patient not to try naturally, because OHSS they can get pregnant naturally also. So premature LH surge, LH more than 10 IU per liter, accompanied by a concomitant rise in progesterone of more than 1 microgram up to 3.2. This is the value in premature LH surge, more than 10. Premature LH surge in the natural cycle seems very rare, but may be more frequent in older women, because their maximum follicle diameter at the time of ovulation is little smaller. Premature LH surges also occur in 25 to 30% of patients of stimulated IUI cycle, and it may it definitely may interfere with the timing of IUI, because the husband may be busy. You've called for a scan, husband may not be available. He may, in our place, they travel, and we tell them, see, after 4 days probably IUI will be there, and they say, doctor, we are going 2 days for some marketing or for work, and they may not be available. So there you may lose a cycle. So you have to be very careful in these cases. Where does antagonist now? How to prevent? Now, if there is a history of premature LH surge in the previous cycle, their antagonist has a role. So when an LH rise is expected, example, previous cycle LH has risen. So, or you want to avoid insemination during weekend, you want to go somewhere. And if the follicles are very big in size, there also you can give. In PCOS subpopulation, older patients with short follicular phase and reduced ovarian reserve where premature luteinization occurs frequently. These are the indications of antagonists. This is due to defective production of gonadotropin surge attenuating factor. So now gonadotropin cycles, yes, definitely they're also because multifollicular development and they are more prone for LH surge. So okay, these are the natural cycle pregnancy rates, clomiphene, letrozole, gonadotropin with antagonists. So we have already spoken about it. So how are the pregnancy rates? In the type of gonad. Now, I want to tell this important point that there's no significant influence of pregnancy rates whether we give with FSH or HMG, the type of gonadotropin is not important. And definitely, this has to be kept in mind. It's not that recombinant FSH expensive cycle will give us more pregnancy rates. How do we convert an IV? Now you have had, say, 4 or 5 or 6 follicles develop, or say 6 or 7 follicles have developed. So what after counseling the patient, if they are okay, you can add antagonists on time, do E2 LH levels if needed, continue the same gonadotropin dose every day. And if you have the facility, you can convert IUI cycle into an IVF. If you don't have the facility, then you have to cancel it. Now, there is this paper, it concluded that IVF ET is an effective method for patients with hyperresponse to ovulation with induction in IUI. We have to remember that it is better for us to freeze these cycles and do an embryo transfer later. So in summary, natural cycle has a role if couple is unable to have intercourse. Donor IUI cycles in ovulatory young patients, we can do a natural cycle. Clomiphene citrate letrozole can be used for ovulation induction and IUI cycle. Gonadotropins have best clinical pregnancy rates in IUI. Cancel the IUI cycles if more than 3 mature follicles. Counseling, written consent, most important for both the partners. You cannot do IUI if the husband is not there. You have to take a written consent from both the partners. If the patient is married, if patient is unmarried single woman, there you can take her consent and you can go ahead. Explain the success rates. Please do not give false promises to the patient. IUI center has to be registered as level 1 clinic in accordance to the ART law 2021. This is for our general gynecologists who were doing IUI earlier without registering their centers. I would request all of them not to do IUI if their center is not registered. It is very easy to register online. You have to apply and kindly register your centers. So thank you so much for a patient hearing.
Thank you so much, Anuradha. I think that was clear. I think you've covered entire, I think whatever people need to know about IUI and ovulation for an IUI cycle. And one like last point, I think nowadays people are prepared in one center and transfer to another center to do the insemination, which again should not be done. It should be prepared and inseminated within 20 minutes, and that is what the recommendation is. Any other questions?
Yeah, I agree with Dr. Kavita that the transfer of gametes is prohibited by our ART law. Earlier, we were preparing him from our center, we were sending to the neighboring centers, gynecologists, but now you should not do. Should not do because it is legally prohibited. Another thing is that if the gynecologist wants to do the ovulation induction, she can do. But for IUI procedure, she should refer to the IVF center or IUS center, which is registered.
Uh,
Any other comment or questions if you want to discuss?
Dr. Monica, your comment,
Oh,
because
Shweta,
you're very
right.
good in these ovulation inductions. I've heard your lecture on poor response, Poseidon and all. Anyone wants to add? Anyone is doing in a different way, has got, Dr. Kundan, any comments?
Hi, Anu. Excellent lecture. I think
Welcome, Dr.
you have
Kundan.
given us. Sorry.
Welcome.
Thank you, Sneha. I think excellent lecture, and I feel you have given a good point that we can reduce combining oral ovulogents with gonadotropins. It gives a kind of a little less expensive. We can reduce the consumption of gonadotropins. In fact, clomiphene is considered a very better ovulation induction drugs. And looking at the plasma half-life, it's 5 to 7 days for clomiphene. So what happens is if you give clomiphene just for a short time, that is second and third day, and fourth day only if you add gonadotropins. So what you do is basically allow that gonadoclomiphene to wash out by the time the follicular, the trigger comes. So giving shorter time oral ovulogents and introducing gonadotropins by fourth or fifth day is going to really help, and we can reduce the side effect of clomiphene. So that was my suggestion. But Anu, I think Anuradha, it was a very excellent lecture, and fantastic. You have given a clear-cut overview about the ovulation induction in IUI.
See, Dr. Kundan, for PCOS patients, also what I do is if they have been stimulated earlier with letrozole and their responses are there, for 5 days, I'll give letrozole only. And I'll do the day 6 scan, and then I'll see whether they need the gonadotropin, maybe one shot, and that too very less dose, 75. I will start because I am worried because they suddenly boom, suddenly they are all fine and you give 150 one shot, and next time you see like ovaries are big and all. So, and your cancellation rates, my cancellation rates of IUI have dropped since I changed this 5-day letrozole and 6-day injection. But yes, you should have a letrozole given earlier, and you should know about their ovaries and their stimulation. The chart should be in front of you, or if you have done yourself, there you can do that.
Yes, you're right, Anu. That was a beautiful lecture, and Kundan's comments were also very, very relevant. And I'll just share a very interesting incident with you. I always used to be a protagonist of when it started off again, 2.5 mg letrozole. Then I think all of us uniformly came down to that 5 mg OD dose starting day 2, day 3. I also have done a lot of work on CC plus letrozole, which I presented in Pune first time in 2008. So now, just now, today, day before yesterday, my friend in Raipur, all of you know her very well. She referred a patient with 0.3 AMH, anesthetist wife, to me. And this lady had taken 3 tablets of letrozole per day, 7.5 mg letrozole per day for 5 days. And believe me or not, on day 12, she had 3 beautiful follicles when she came to me. Left side, she had 11 and 12, and right side, she had 15 mm. So I just waited for a day or two. I gave her a trigger. Even though she had 3 follicles, but one was 11 or 12, the second was 14, the third was 19. I gave the trigger. Today, I did the IUI. I found that a very magical figure, 7.5 mg. So another of my patient with low AMH, I use this dose only. So sometimes, you have to, learn from your friends, colleagues, how they work. And I agree with Anu, I'm not that liberal with gonadotropins also. I also, take some time for my oral ovulations to work. And after a good scan, I start gonadotropins. But I think my colleagues in Maharashtra, they are, whoever refers a patient to me, that patient starts gonadotropins something like day 3, day 4, day 5, very early. Yes, Kundan?
Yeah,
Because
we started by fourth day
yes,
generally
because
after
literature
giving 2 days of oral
results are
ovulogents.
better. All literature says the results are best with gonadotropin cycle. So that's the thing. When you think of evidence, you use gonadotropins. When you think of prudence, you think of, wait and watch. Thank you.
See, look,
I
only
think
one.
it also depends on whether your patient is a poor responder or a normal or a hyper responder. So that is the basic of our, whatever we do. And also, I think we have to be patient. I have learned patience over time, where you have counseling skills. When you improve on that, you can easily change your practice.
Yes, that experience really counts, Anu. Like, I also feel that we have matured over the years, become more mellow in our approach, become more patient to patients, become more humane, become more understanding. You feel the patient's pain more than the younger gynec. You feel the patient's pain also. Yeah, when she gets when the IVF doesn't work out, or that
So
time.
let us move ahead with the third talk now. Our speaker is waiting, Dr. Shweta Mittal. Welcome, and over to you, Dr. Monica, for the short introduction of our chairpersons for this session.
Sorry, ma'am, we just get carried away when it is, an ISAR webinar. I'm sorry for the delay. And now for the third session, I have a very dear friend who is General Secretary of IFS, Dr. Shweta Mittal, with us to chair her talk on oocyte cryopreservation and elixir of youth. We have Dr. Kundan V. Ingle, the immediate past chairperson of Infertility Committee of FOXI, at the honor and privilege of working with him. And he is also the managing council member of ISAR, director of Nirmati Clinic, a center for assisted reproduction and endoscopy in Pune, vice president of Pune Obs-Gynae Society, founder treasurer of Maharashtra chapter of ISAR, presented several research papers in SRM. One of his favorite studies is that which compared valerate with hemihydrate estradiol. And I also wanted to do a study, but he had already done it. He's owner of Moses Cradle ART Bank in Pune and presented first-time research at the 6th Kogi World Congress in Vietnam on the use of GCSF subcutaneously for thin endometrium. We are always arguing, Kundan and I, which is better, the subcutaneous route or the intrauterine. So, Kundan, I'll also introduce your co-chair for today, Dr. Mitsu P. Doshi. Madam is a well-known gynecologist, obstetrician chief consultant of Me and Mummy's Hospital in Surat since the last 3 decades. The medical director and IVF consultant at Blossom IVF Center of Surat, which is an advanced infertility training center of IVF various centers of USA. She has delivered several talks for public health awareness on local channels and various clubs. Some of my very fond memories of Dr. Mitsu and Dr. Praful sir are traveling on Asia trips with them and enjoying the Gujarati snacks. Over to you, chairpersons, to introduce our speaker.
Thank you, Monica, for those kind words of introduction. On behalf of my co-chairperson, Dr. Shweta Mittal, Dr. Doshi, let me introduce Dr. Shweta Mittal. I think, yes, as you said, she's a very dear, close friend. And we have heard Shweta, excellent orator. It's a privilege to introduce you, Dr. Shweta. She's a senior consultant and leading IVF specialist and gynecologist at Sir Gangaram Hospital in New Delhi. Yes, she's a general secretary of Indian Fertility Society. She's been a past co-convener for research and methodology special interest group for IFS. She was past editor for IFS. She was past member of Infertility special interest group for FOXI. And she holds also a huge footage into endoscopy, which she's trained from Germany, fellowship from Germany, and as well as fellowship in IVF from Israel. And she has received excellence awards for her contribution, like Dronacharya Award. She's received from Economy Times Award for Inspiring Gynecologist and India News Award IVF Gynecology Conclave in New Delhi. I think she's an excellent orator, and she's going to talk about oocyte cryopreservation. We know oocyte cryopreservation is something which has been utilized for fertility preservation for those young patients or reproductive age group patient who suffer with cancers. But I think nowadays what we have started seeing is because of increased awareness and delayed marriage, and girls starting understanding that yes, I can delay my fertility and as well as I can conserve my fertility. They are coming ahead on their own alone to opt for oocyte cryopreservation. So I think new indications are coming. There are even I have seen girls who are working into medical field. They know about increasing incidence of ovarian reserve, but they are young. They are not planning for marriage, so they know that my reserve is low, so I should go for oocyte cryopreservation. So there are scenarios that as the technology and solutions are available, I think new indication comes out that we can we start using this. So Dr. Shweta is going to give us all the details. Very beautiful name she has given, or we have given to her, that is oocyte cryopreservation elixir of youth. So I think we are really eager to hear from Dr. Shweta. Over to you for your crisp and focused presentation on oocyte cryopreservation.
Thank you, Dr. Kundan, for such warm and kind introduction. And thank you, Dr. Monica, on behalf of ISAR. I'm giving my greetings to ISAR group. And let's see us a little bit of evidence when it comes to how do we stand in India at the moment. Let me just share. Just a second. Just need to take one bar out. Okay. Yeah. So the topic given to me, I thought we'll discuss, that is oocyte cryopreservation in reality and elixir to youth. The first human pregnancy from a previously cryopreserved oocyte was reported in 1986. So it's not a new technology. In the last 20 years, what has happened is that the process of vitrification has become a standard protocol for oocyte cryopreservation. And the reason is because intracellular ice crystal formation is minimized compared to slow cooling, resulting in improved post-warming oocyte retrieval. So initially, I remember when I started my fellowship in 2001, every freezing was by the slow method. And then slowly, vitrification took over. I remember around 2015 or so. And then there was a paradigm change in the results, which came because vitrification improved the thawing results of an embryo and as well as the oocyte. Now, until 2013, it was called experimental, but at that point of time, American Society of Reproductive Medicine, the practice committee stated that oocyte freezing is not experimental anymore, and it was allowed for its routine use in post-menarchal women facing gonadotoxic therapies. Now, oocyte cryopreservation can be an emergency oocyte cryopreservation, or it can be planned. Now, what is the change which has happened is we use the word social egg freezing, voluntary egg freezing. But ASRM suggested that instead of using this word social egg freezing, how we don't use menopausal clinics anymore, we will use matured women clinics. So they said, let's use the term planned oocyte cryopreservation for whatever indication the woman decides to do that. Now, the question arises is, why the need to freeze the eggs? So few places, I think very important is that every center should learn in an emergency egg freezing. Now, why? There could be a situation where on the day of egg retrieval, there is absence of sperm, inability to produce, or an absence of partner. You could have had situation where, in a very busy IVF center, it is not possible to freeze all the semen samples before performing an IVF. And maybe there was a catastrophic event in the family. Maybe the husband could not travel. Maybe the flight got cancelled. So the center needs to have the expertise to do an emergency egg freezing. So in the beginning, when we were, started off with egg freezing, there were two indications where we were doing it slowly. That first emergency egg freezing came in one day and we thought, yes, we are going to go ahead. And then over a decade, there are so many indications which came in, so many more number of oocytes which were frozen. Then it allows a set of women to conceive with their own oocytes at a later date. And that is social egg freezing, women who want to postpone their childbirth, or medical, egg freezing, pelvic cancers requiring chemo or radiotherapy, women who are prone for premature ovarian insufficiency, like carriers of Fragile X mutation, if they know that their mothers were also carrier and they happen to have. So recently I got two sisters where one completely into premature ovarian insufficiency. So I got an FMR premutation done. She was positive. So I got her younger sisters done, and luckily it was negative. Otherwise, I would have offered her the younger sister oocyte cryopreservation because the elder one had already gone into established POI. Then comes oocyte donation programs. Now, with the advent, of different laws in India, so right now we are not getting into oocyte freezing for oocyte donation programs. But then, yes, when our ART banks mature and there is additional, clauses in the laws, because all across the world, oocytes are mostly provided as frozen oocytes, and it is a very, very robust program in these centers. So when I talk about plant egg freezing, fertile women who wish to postpone motherhood for various reasons, they have education, they have career demands, they haven't found the right partner, and then social egg freezing trends have slowly emerged, even in women in their 20s or early 30s. So this is the trend as per the HIFA data, that how from 2010 to 2016, the indications for egg freezing and the number of treatment cycles for egg freezing started increasing. So there were two reasons. On one hand, the centers were getting the finesse in egg freezing programs, and on the other hand, social awareness was increasing, and more women were thinking about it, that, okay, if I want to delay my fertility, then what is the option I have? Then in the presence of a successful egg freezing program, now this happens all over the world, so it's important for all of us to know. So number one, egg donation could have been anonymous, but in India now the ART bill does not mandate anonymous egg donation anymore. Now eggs could have been quarantined, would have been a nice thing, and tested for all STDs. How in the earlier law for semen it was that you have to quarantine the semen sample and then release it. Eggs from one donor could have been donated to multiple recipients, therefore optimizing the oocyte usage. But in India, now it is not allowed. So one donor and one recipient. And process becomes less tedious since presence of recipient sperm is not a prerequisite, and freezing can be undertaken immediately after retrieval, unlike waiting for embryo freezing and embryo outcome. Then egg donation opens the door for fertility of many types of infertile women if these oocytes were available, with premature ovarian failure, with advanced age, with repeated RIF, and with transmissible genetic conditions. Now, achieving pregnancy with cryopreserved oocytes is not easy. So it sounds easy. What is important is that when centers get into oocyte freezing program, they need to validate their results with thawing, survival, fertilization, and pregnancy rate, what they are achieving with frozen oocytes. So just by putting them in the tank does not mean that you're running a robust or a successful oocyte cryopreservation program. What is the optimal timing for elective egg freezing? The highest probability of live birth was seen when oocytes cryopreservation was performed at ages less than 34 years, that is more than 74%, although little benefit over no action was seen at ages 25 to 30 years, which slightly increased. So this was Messin et al. Published in Fertile Sterile in 2015. Now, what strategies to be adopted for fertility preservation in these girls? So, oocyte cryopreservation, you have to freeze mature oocytes. This is the choice for postpubertal girls, and vitrification technique, which involves rapid cooling in presence of high concentration of cryoprotectant. The procedure of oocyte vitrification then guarantees high survival rates and optimal cell competence after thawing. These are stored in liquid nitrogen in minus 196 degrees, and as per the law they can be stored up to 10 years, and if you need to store them further, then you need another approval from the national board, and you can still continue doing it. Now, one indication which has come in where I think we as gynecologists need to be sensitized are young girls with severe endometriosis, with large endometriomas. So see on the right side. Now, if there is a unilateral endometrioma with normal ovarian reserve, then you don't need to go for oocyte cryopreservation if you're less than 30. You have a normal reserve, you are more than 30, you have an ovarian reserve with unilateral endometrioma, and you have low ovarian reserve, or in case of bilateral endometrioma, recurrent endometrioma after surgery, endometriomas growing fast, and endometriomas at a very young age, discuss fertility preservation. And if surgery is indicated, of course, oocyte vitrification is the best option for post-pubertal girls. But if you're doing a surgery, then yes, you can simultaneously do an ovarian tissue cryopreservation also. I still consider this is more at a nascent phase in India, even though there are, centers performing ovarian tissue cryopreservation, but we don't have any reported pregnancy from India right now. So important is discuss fertility preservation, and this is one extended indication is ovarian endometriosis. So we need to be sensitized about it. Next, what happens after egg freezing for social reasons? Well, the data said the follow-up data was scarce, which was published in 2016 by Cobo et al. And as per their data, only 8.7% of 1382 women who underwent social egg freezing returned to use their eggs after a mean duration of about 2.2 years. The oocyte survival rate that time was 85%, clinical and ongoing pregnancy rate was 39 and 27%. 45 out of 90 women who were single at the time of cryopreservation had a partner when they returned. So the problem is that most of the times when there are voluntary egg freezings just to delay fertility, most of these girls may not need it, may not get a partner, may never come back to you. So in next 5 years, you would see that these, oocytes are going more or less in the tanks, but they're not getting, used as such. So now there are a couple of questions which come to our mind when we talk about oocyte freezing. Now, what are the expected live birth rates for women who undergo a planned oocyte cryopreservation? It's a critical question whether lifetime autologous live birth rates differ between women who have cryopreserved oocytes and those who do not. Whether in a non-donor oocyte population, live birth rates differ between fresh and cryopreserved oocytes. So Doyle et al. Identified all autologous IVF embryo transfer cycles of warmed vitrified oocytes performed at their center between 2009 and 2015, amounting to 128 cycles. The number of M2 oocytes inseminated was lower in the vitrified oocyte group, but the fertilization rate with ICSI was comparable between the groups. Significantly fewer cycles resulted in blastocyst stage transfer when comparing vitrified versus fresh oocytes. However, there was no difference in percentage of cycles without an embryo transfer. So the cancellation was the same between fresh and vitrified. Implantation and clinical pregnancy rates were good. They were significantly higher among embryos derived from vitrified oocytes, and pregnancy loss per clinical pregnancy adjusted was greater among the vitrified oocytes. So they did not find that it was inferior as compared to a frozen embryo. Then the next question is, what are the live birth rates for infertile women who use autologous cryopreserved oocytes for indications other than, planned oocyte cryopreservation? So Almudin et al. Compared 79 cycles in which patients underwent fresh IVF to 46 cycles among patients who failed fresh IVF and subsequently used their supernumerary vitrified oocytes. So the pregnancy rate per transfer was similar between fresh versus cryopreserved warm groups, 51% versus 45%. Miscarriage and live birth rate also per transfer were comparable between embryos derived from fresh or cryopreserved oocytes in both studies by Almudin et al. So the live birth efficiency per warmed oocyte by age group and was found that oocyte efficiency decreased with increasing age, 7.4% for women less than 30 years, 7% for women 30 to 34, 6.5% for women 35 to 37, and 5% for women who were more than 38 years of age. So it is recommended that oocyte cryopreservation to be offered as an option for women in situations where there is an unanticipated lack of sperm on the day of oocyte retrieval or a desire to limit the number of fertilized embryos. Now, the next question is, Among women pursuing oocyte cryopreservation, how many mature oocytes should be cryopreserved to achieve a reasonable chance of live birth? Because this is a question what patients would be asking you. And let's back up, our replies with some data. So there are no RCTs to address the number of oocytes needed to achieve a reasonable chance of live birth. But looking at the algorithm to achieve a 70% chance of one live birth, women who are between 30 to 34 years would need about 14 mature oocytes, 35 to 37 years, 15 mature oocytes, and 38 to 40 would need around 26 mature oocytes. So we can ponder over the fact that if a 40-year-old lady comes to us for cryopreservation, are we even doing justice by telling her to go through one cycle? Maybe she'll need 2, maybe 5. See the number of oocytes, but on an average, for a younger patient in our center, we are looking at least 12 M2 oocytes to be frozen, because freezing oocytes is not the answer. Having a live birth rate or a predictability of a superior live birth rate out of these frozen oocytes is something what we need to look at. So oocyte efficiency decreases with increasing age, but there are limited data to specify the optimal number of oocytes needed with planned oocyte cryopreservation. Now, the next question was that among women cryopreserving oocytes for any indication, whether it's planned or unplanned, do baseline demographic characteristics or comorbidities at the time of freezing independent of age? So like BMI, smoking, ethnicity, they impact the outcome. And these are their factors at the time of warming that impact outcomes. So are there ways where you can optimize the cycle outcome? So the answer is that there are actually no RCTs evaluating baseline demographic characteristics or comorbidities at the time of oocyte cryopreservation independent of age. But the recommendation by ASRM is that there is insufficient evidence to recommend that, you change your demographic or comorbidities independent of age and then go for oocyte cryopreservation. Possibly you can do that and go ahead. And definitely there's insufficient evidence to recommend interventions to optimize the outcomes after planned oocyte cryopreservation. But we know that if they reduce their BMI, they stop smoking, then it definitely, or control diabetes, so they will be having better pregnancy and neonatal outcomes. So what happens after egg freezing for social reasons? This was a survey of 96 women. Average was 37 years and average number of oocytes stored were 40. 14 in this study, only 6 women returned to use their eggs, and most pregnancies that occur after egg freezing are from natural conception. And we know this is a fact. This is a fact. So this is just a small data from Gangaram Hospital, where we have done freezing for 119 women, 50 for social, that is planned, married women, 29. DR cycles initially when we were doing, this is how we validated our results: 9 emergency freezings, 20 fertility preservation, 20. The utilization rate has been 5, 6, 7, 14. And in fertility preservation, women haven't come. No, they need to have a survival rate. They need to be disease-free. They need a clearance from the oncologist. Maybe their marriage needs to be going on well. They have to be, physically and mentally fit to carry pregnancy. So that is very, very important to understand. So the survival rate, we have achieved over 95% with a fertilization rate of 64% and a pregnancy rate per embryo transfer of 62%. And so this is how we validated our data by freezing some sibling oocytes in donor cycles initially, thawing them, fertilizing them, and looking at the pregnancy rate. And when we reached the benchmark, now we can assertively say that yes, our freezing program in oocyte cryopreservation is a very robust program. So in the end, egg freezing, some simple understandings, it does give a best chance of successful live birth rate in following oocyte cryopreservation, preferably prior to age 34. Single women approaching their late 30s who desire biologically related children in the future must consider egg freezing before 37. But clinicians need to be honest with women when they go for treatment, their chances of success, about the roller coaster treatment they're going through, and their realistic chance of having a baby at the end of the day. Currently, follow-up data is scarce, and are very few women, they return to use their eggs. So thank you so much for patiently hearing me.
Chairperson.
Yeah, Dr. Mitsu, would you like to comment first?
Yeah, thank you. It was an excellent lecture, and it is the need of the hour now. We get so many queries for the egg freezing, and the indication of endometriosis that was highlighted in, because we get so many patients of endometriosis, is very good, that we should consider egg freezing in those women. Thank you so much.
Yes, Dr. Shweta, I think wonderful lecture. You have touched upon those important points, practical points, which we need, all of us, we need to know about oocyte cryopreservation. I think I'd like to give two comments about oocyte cryopreservation. One is very important thing that we have to consider about those, the last point which you mentioned about that age, BMI, and the habits and those things, because these things, they do affect the oocyte quality. It's not the numbers but the oocyte quality. I think we need to, as a clinician, we must speak to the lady or a woman who wants to preserve her oocytes. We must tell her the realistic outcome, because that's what we face it when we thaw them and look at their outcome. And we must take down in consent, because as you said, fertility preservation, they really take time to come out of that cancer situation, recover, become healthy, and then plan for fertility. I think these oocytes of these patients, they remain with us for a longer time. So we need to have in writing very properly, in the case of unforeseen events like a death or a morbidity or whatever, they might get married in between and still she loses her life. So what should we do in such scenario? We have to have put it into the consent right away when we are doing a oocyte freezing. I think many times which I've seen, people do, even patient themselves, they do not select the options which is already given in the consent form, and we as a clinicians in a hurry, we don't even sometimes look into. But in such cases, especially where we are doing oocyte cryopreservation for a longer time, I think we need to personally check that whether the options have been selected or no. These are the two important points which I wanted to. But I think, Dr. Shweta, I think excellent presentation. You have really touched upon those practical points and issues. If there are any questions in the chat box, Dr. Monica, we can take it now. I don't. 1 minute.
No,
I
there
don't
is
see
no
any.
as
Yeah.
such, because people are just zapped by the talk.
Yeah. There are no questions.
So what you
actually.
said was really true, because long back when our ART bill was not, the consent form did not have, and I came across this for a very young boy with frozen semen, where we had to send this plea to the High Court, because there was no column when ICMR was there, that what happens to posthumously to the frozen gametes of a young child.
Absolutely.
And the parents basically wanted to use it for surrogacy, which was not allowed. So this is very, very important, that what happens, and that is why I showed this data, that in cancer freezing, just see, because see, this technique has been very, I would say, has become very robust in the last 7 or 8 years. So this is a short duration of time, and the youngest girl where I did freezing was, of course, 16. Now, when will she come? Will she survive? And she had a uterine sarcoma. So will she even get a partner and have a surrogacy? So it's such a futuristic, I think, situation.
You're right,
So,
Shweta.
I
Yeah,
think
Dr.
Dr.
Anuradha.
Anuradha wants
Dr.
to.
Shweta, yeah, I think Anu wants to say something. Please go ahead.
I have one question, that supposing the patient does not pay, we generally take a annual payment for freezing. Now, supposing the patient fails to pay, what do we do in those
So
situations?
now the consent form says that you will have to pay the renewal fees. So then you will, as per the consent, then you will send them a registered, an acknowledged registered information. You can have your own protocol, 1, 2, 3. They don't respond, because it is the responsibility of the patient to inform the center, change of address, change of contact number. And if they do not pay the annual fee, then yes, you have the liberty to discard these gametes.
Anuradha, in fact, the consent clearly says, and where the patient signs on that consent, that it is the patient's responsibility to contact the center within 3 months prior to the last day of consent. So it is already mentioned in the consent form that they have to contact even before the year finishes. Now, if in case failure of payment by the patient, after 1 year, a center has a full right to discard it without any notification to the patient. It has been clearly mentioned in the consent. Though we, as a center, we sometimes we are emotional. We don't do it. We may communicate. It's a good practice. Okay. But it is not a liability and compulsion on us anymore. It is the patient's responsibility. And that's what I always feel, that we just don't take consent. We must explain them the meaning of what is written there. So they are also very clear that, yes, it was informed to me. See, the only problems happens when they don't get that information because they don't read. Sometimes they don't understand those meanings. And that's why that informed consent is very important.
So the consent which has been made by our, the ART law, everybody should keep the Bayer's book, the Bayer law book, have the same consent the way it is. And if you have an extended consent, get it signed more. But that consent, you should not change. Do not change even one wording of that consent. So get it signed the way government wants us. And then I know that there are many extended, wordings, which we have also done in Gangaram Hospital. So we have an added consent which we get it signed.
So by these consents, we are absolutely legally safe. That's what I want to ask.
Yes,
That
we are.
supposing they have not responded, and then 1 month later they suddenly turn up, and they put up a case that they didn't tell.
No,
We didn't. I mean, sometimes we don't read
the
mail
act
or
will
post
support
my
you
hand.
because it clearly mentioned in the consent form. The one document is enough, okay, where they have signed it. All right. So if they contact 1 month after they finish their expiry, and by that time you have discarded, which we generally don't do it, but we discarded, the law will, this consent form is itself is a very important form, which in a court of law will be evidence in protection for you. Okay. So,
very rightly said, Dr. Kundan. You're talking about documentation of the communication. Whatever you communicate with the patient, the informed consent should be documented, and you have to, communicate the documentation. That means you have to say them that whatever you have said, that is already documented. So they are also aware, and they are responsible for their actions. So
there is an undertaking which there's an undertaking which my hospital has made where the patient signs saying that the information given by the patient is correct, and if there is any deviation from the information, then patient is liable and not the doctor. So you are giving us the Aadhaar card, you are liable. You are giving us the marriage certificate, you are declaring that you are giving correct information. Because these situations we have faced in the past. So we have been evolving and changing, just like the Western world, where they have 50 consents, for everything.
okay. Thank you, Dr. Shweta, for your all the academic contributions and your comments on the different scenarios and questions. And I think thank you so much, Dr. Sneha, for inviting us to chair this session on behalf of Dr. Mitsu Doshi also. And Dr. Monica, thanks to you for even giving us chance to be a part of this very nice gathering. So over to you for your next session.
Yeah, thank you so much, Kundan and Mitsu, and of course, my
Thank you so much.
thanks to all of you for supporting my candidature, of course, voting for me. Thank you so much. And Dr. Shweta, actually, two comments from my side. One, as Dr. Kundan has said very rightly, that the new indication is coming up. The generation who is now, facing the age because of their career-minded approach towards this. And of course, whenever we talk about the breast cancer in younger generation nowadays, before going ahead with any treatment, we'd like to involve the ART consultant, and of course that also has a place for oocyte retrieval. Cryopreservation.
Absolutely, yeah.
And a lot of leukemias also, ma'am. A lot of leukemias now cropping up in the younger generation. So over to the, thank you for the brilliant third session, speaker and chairpersons. We move on to the last session of the evening. That is, we are talking about failing ovaries, the management conundrum, and this is being taken by a very, very accomplished academician, Dr. Padma Rekha Jirge, who is chairperson, Maharashtra chapter of ISAR. We keep reading her articles. They are on the net and everywhere. So to chair this session, do we have Dr. Ashish Kale, Sahiti? And
No,
Dr.
No, ma'am.
Dr.
I don't-
Praful Gupta is there? Otherwise,
Yeah,
Dr. Dr.
Mitsu, Dr.
Madam
Mitsu.
Mitsu, ma'am, Praful sir is there? Otherwise, Dr. Mitsu can continue chairing, I think.
He's there, no, Arun.
Acha, Praful sir is there.
You can introduce by the time.
Good evening, Dr. Praful, and he'll be chairing this talk. Sir is right now president of Surat OBGY Society. So he is a very, very a renowned gynecologist of the Diamond City from MP Shah Medical College, Jamnagar, and post-graduation from BJ Medical College, Ahmedabad, a diploma in advanced endoscopic surgery from Germany, IVF training from the US and Australia, Professor of Gynecology at the Medical College of Jamnagar and Surat, and Senior Consultant at Blossom IVF Center and me and Mummy Hospital and IVF Center in Surat. We welcome you, Praful sir, and we request you to please introduce Dr. Padma Rekha Jirge.
Thank you. Thank you, Monica. Thank you, Dr. Sneha, for giving me this opportunity. I have to introduce Dr. Padma Rekha.
Yes, sir.
Yes.
Yes. Dr. Padma Rekha Jirge is a clinical scientific director of Shushruth Assisted Conception Clinic and Shreyas Hospital, Kolhapur. And she is the founder director of Prismatic Research Foundation. She has many publications, and they include latent genital tuberculosis adversely affects the ovarian reserve in infertile women. Even latent genital tuberculosis, that's the news. Resuming assisted reproduction services during COVID-19 pandemic. All are quite interesting topics, I suppose. Association of AMH and AMHR2 gene polymorphism with ovarian response and pregnancy outcomes in Indian women. So I will not read out all of them, but they are very interesting titles of all the articles. And she's the chairperson of Maharashtra chapter of ISAR in 23 to 25, president-elect of Fertility Preservation Society of India, again 22 to 24, and chairperson of SIG Reproductive Endocrinology, PCOS Society of India. She has been editor-in-chief of Journal of Human Reproductive Sciences, impact factor for the journal, and reviewer for the Fertility, Sterility, Human Fertility, Cambridge, and Reproductive Biology. No wonder that she writes such an interesting titled articles. Stage is yours, Dr. Padma Rekha. Thank you.
Sahiti, please kindly share the screen with the slides.
Okay, ma'am.
Has Madam joined, Monica?
Madam, we are playing her talk now. She's joined. Yeah. Sahiti,
This
please.
peeling ovary is more and more into
Mhm.
picture because of the new law in which a woman can donate the eggs only once, and will be with the dearth and shortage of the ovum donors. I think we'll be required to stimulate more and more people who are in their end stage of their reproductive career, where the ovaries are failing, and how to stimulate those ovaries is a really management conundrum. So, Dr. Padma Rekha.
I would like to thank Dr. Sneha and Dr. Monica for inviting me to be part of this program, Benchmark with ISAR, on the eve of World IVF Day. And the topic, the burning issue I would be addressing would be failing ovary, a management conundrum. As we know, that of various issues we deal with when we are taking couples through IVF, or in fact, while treating them for infertility, one of the most prevailing scenario is reduced ovarian reserve. and let us see how we can effectively manage this scenario. So at the outset, I would like to, distinguish between poor ovarian reserve, poor ovarian response, and premature ovarian insufficiency. We know that of the group of women who have poor ovarian reserve, that is number of eggs in the primordial follicular pool below the 5th centile at any given age, only a percentage of them will actually will eventually go through IVF, which is when we make a diagnosis of poor ovarian response. That is when they yield less than 4 oocytes with conventional ovarian stimulation. If you look at how prevalent it is in Indian scenario, we need to go back to the Nari registries we used to get a decade before the national registry became available. So the one data from 2012 shows that 20% of the cycles yielded less than 4 oocytes. And even in egg donors, it was nearly 11% of them with 4 oocytes. And women who went through IVF, nearly 54% of them went through egg donation cycles because of reduced ovarian reserve, and another 26% because of premature ovarian failure. Of all those who went through IVF for reduced ovarian reserve, majority were for reduced ovarian reserve, whereas nearly 27% were because of premature ovarian failure. So when we talk about premature ovarian insufficiency or premature ovarian failure, this is the end stage of reduced ovarian reserve, where it is a hypergonadotrophic state, where the FSH levels are high and AMH levels are indeed very low. Why are we concerned about poor ovarian response? Is that because we know that as the number of oocytes increase in response to ovarian stimulation, the chances of achieving pregnancy increases. So compared to somebody who has less than 4 oocytes, for each additional oocyte, there's a significant improvement in the pregnancy rate, and hence we are very concerned indeed about the reduced response. It has other significance in that the most important significance is that such women have reduced reproductive span, which is not very often discussed, and also age-wise they behave differently. Young women with reduced ovarian reserve tend to have reduced quantity. If treated at the right time, they would still have a good chance of achieving pregnancy, whereas older women, in addition to reduced quantity, they have poor quality of the oocytes as well, and that adds to the problem of the situation. But what happens in routine course is that whether somebody has very good ovarian reserve or low ovarian reserve, the rate of recruitment of follicles into the growing pool varies, but eventually under natural circumstances or when they're going through simple ovulation induction, they would go through a monofollicular ovulation. So we never actually can diagnose the presence of premature ovarian failure or premature ovarian insufficiency as long as they're having regular cycles or some follicular growth, and definitely reduced ovarian reserve by just looking at the follicular growth, because we would just normally label them as unexplained infertility unless they're evaluated more aggressively. So the most common cause for reduced ovarian reserve is physiological, that is women in their late 30s and early 40s. However, pelvic infections like tuberculosis can damage the ovarian function, as is previous ovarian surgery, particularly for endometrioma or indiscriminate ovarian drilling. There could be some genetic causes such as receptor polymorphisms, BRCA mutations, and Turner mosaics. Autoimmune disorders, particularly rheumatoid arthritis and thyroid disorders, previous gonadotoxic chemotherapy or radiotherapy, environmental, which is not very often addressed, and certain ethnicities, including our Indian ethnicity, can all be responsible for reduced ovarian reserve at a younger age than expected. So there have been some efforts made to identify these women before they go through the first cycle of ovarian stimulation for IVF, and Bologna criteria was the first one which tried to identify those who were at advanced maternal age and had lower AFC or AMH than normal. But now the most widely used criteria are the Poseidon criteria, depending on the age. If they have reduced ovarian reserve markers such as AFC less than 5 and AMH less than 1.2 nanogram, they are classified as expected poor responders. So if they're younger than 35 years, they're considered as Poseidon Poseidon group unexpected poor response as Poseidon group 1 and group 2, depending on the age factor. If they're below 35 or above 35 years, when they have unexpected, poor response despite normal ovarian reserve markers, or their expected poor responders, they belong to group 3 and group 4 if they have low ovarian pre-stimulation, low ovarian reserve markers. So what we are concerned here are the group 3 and group 4 who we can actually identify as expected poor responders. And let's see what we should be doing in them and what the evidence is, whether we should be offering them expectant management, whether multiple cycles of ovulation induction, any adjuvant therapies should be considered, IUI, multiple IUI cycles, or early recourse to IVF. What the evidence says that AMH is the earliest marker to show decline in ovarian reserve. So in somebody who is diagnosed as unexplained infertility, if there is low AMH, that should be the first warning bell to say that this person is very likely to be a poor ovarian, likely to be having poor ovarian response. So that is AMH less than 1.2, between 0.5 and 1.2 is very suggestive of very reduced ovarian reserve and very reduced pregnancy happening beyond 18 months or so. So what is very important in them is to counsel them, fast-track treatment, and consider any adjuvants or supplements prior to starting the treatment, and try and expedite treatment. Counseling should also include the very low chances of pregnancy rate with IUI in such women, and the information that maximum success rates are achieved in the first two cycles of IUI, and any further IUI could be not beneficial in them, should be imparted with during the counseling, and try and counsel them and educate them to act fast and take the appropriate decision. It's also important to note that these women are likely to achieve a very low success rate with IUI, which is less than 5%. So giving them the objective evidence does help to direct them to change their decisions or modify their decisions and avoid unnecessary wastage of time. Also, the Poseidon group has this ART calculator, which is very helpful in counseling them as to when we are discussing poor ovarian response and probable number of cycles to achieve a pregnancy, or probable number of oocytes required to achieve euploid embryos. This ART calculator is helpful in such counseling. So once we have decided upon the course of treatment and that IVF is the most appropriate treatment, then how do we go about it? What are the stimulation strategies? So just looking at the number of protocols which have been tried and tested over the last 2 to 3 decades just goes to highlight how difficult the scenario is and how minuscule improvements have been achieved despite all the advances in the field of IVF in this regard. So for a long time, there is evidence to suggest that whether we choose long agonist protocol or an antagonist protocol in poor ovarian responders. Apart from the number of days of stimulation, the chances of achieving pregnancy are very similar in both types of protocols. One scenario where long agonist might be more helpful than antagonist is where there is difficulty in synchronizing the follicular growth or follicular recruitment, where we are having distinctly different sizes of follicles growing at different times. So just to achieve more synchronization, an agonist protocol might be preferred. Whether we should really offer any kind of stimulation at all, if they are going to yield very low number of oocytes, is another important question to be addressed. And this this large amount of data, including more than 3,000 patients with poor ovarian response, did very clearly show that compared to natural cycle, any form of stimulation, whether it is mild or long agonist, short agonist, or antagonist protocol, will all result in a better pregnancy rate. Now, coming to mild stimulation versus conventional ovarian stimulation. So, mild stimulation is considered as a very important step to achieve pregnancy in many of the women with poor ovarian response. And it is very important to see what the evidence says. So, when we compare mild stimulation to conventional IVF, as far as live birth rates are concerned, there is no difference. However, the number of embryos achieved is significantly better with conventional stimulation, and also a non-significant improvement in the number of high-grade embryos created. What the evidence does show that whether we use mild stimulation or conventional stimulation, the chances of achieving live birth are very similar, but the number of cycles required and hence the duration required to achieve pregnancy is reduced with conventional stimulation. So if we are going through conventional stimulation, what should be the starting dose? It is generally agreed that the starting dose should be higher than what we use in normoresponders, and most often the starting dose used is 3,000 international units per day. And then, with the increasing knowledge about how the ovarian follicular recruitment happens in a natural cycle, initially the belief was that there was one set of follicles growing in each cycle. But however, in the last decade or so, again, we have understood that in each ovarian cycle, there could be 2 or more, 2 to 3 cycles of follicular growth, and utilizing this, it creates 2 important opportunities that we probably will be able to get fertilizable oocytes, and we might be able to achieve pregnancy starting stimulation at any time of the cycle. And actually, we can do more than one stimulation in a single cycle. Both these opportunities were put to use in the context of fertility preservation, where in some going through any treatment for malignancies, particularly before receiving gonadotoxic chemotherapy or radiotherapy. During the short interval available, they would go through these kind of stimulations to achieve as many oocytes as possible, which could be cryopreserved. And the same phenomenon has been used in poor responders as well to achieve more oocytes within a single cycle. And the concept of dual stimulation or duostim has been increasingly used in these women, where they go through the first follicular phase stimulation and retrieval, and the resultant embryos are frozen. They are given continued GnRH antagonist for another 3 to 4 days to cause luteolysis, and another stimulation is initiated to retrieve oocytes in the luteal phase, and again embryos fertilized, and oocytes fertilized and embryos frozen, so that they can be transferred at a later date. However exciting this could be, or attractive this could be, we need to bear in mind the cost of the treatment more than doubles up, because we need to stimulate the ovaries twice, and we need to freeze the embryos twice, and then consider transfer. So we need to weigh the pros and cons of efficacy versus cost of the treatment. And the current evidence does not strongly support routine offering of dual stimulation to all those who are diagnosed as poor responders. What about adding LH? Because we know that LH is essential for adequate follicular growth from the mid-follicular phase onwards. But what is not very well appreciated is that LH is also required to sensitize the follicles to FSH. So even though its role at mid-follicular level is, follicular phase level is very well appreciated, the second phenomenon that it actually also plays an important role in the early follicular phase is not very well appreciated. So hence, when LH is considered necessary, definitely in expected poor responders or previous proven poor responders, if we are adding an LH activity, it should be from the beginning of the stimulation rather than halfway through the stimulation. So definitely in those who are older women and those who are poor responders to monotherapy with recombinant FSH are the two categories where it could be added to improve the cycle outcome. What about adding other adjuvants? So, of course, the three important molecules that have been used are growth hormone. Consistently, there is variable results as far as use of growth hormone is considered. It's either used daily along with gonadotropin stimulation, or started from the day 21 of the previous cycle. When we look at the RCTs, any benefit that has been seen to be obtained with growth hormone is probably because of starting it earlier than incorporating into the follicular phase stimulation protocol. Dehydroepiandrosterone supplement is another very widely used because of ease of administration and cost compared to any other adjuvants. And again, there is consistent evidence in the recent years to show that it does improve the outcome, including the pregnancy rate and live birth rate. Testosterone, the results have been varied. The meta-analysis prior to this one did not show any improvement, but this meta-analysis does show a better pregnancy outcome in women with poor ovarian response. Coenzyme Q, this is the only study which has looked at the supplementation with coenzyme Q10, and this has shown to improve the oocyte and cumulus cell quantity and quality by improving the mitochondrial metabolism in females with advanced maternal age. But we have to remember that it's very widely used in clinical practice, but the evidence as far as published literature is concerned comes from a single study. So what about apart from, like modifying the dose, using the conventional protocols, or choosing one of the alternative ovarian stimulation protocols, and also adding various adjuvants, what other things can be done in those with very reduced ovarian response? Obviously, in the recent years, 3 procedures or 3 interventions have raised a lot of interest, and one of them is the ovarian fragmentation and follicular activation, or more commonly known as in vitro follicle activation. The second one is the introduction, autologous ovarian stem cell transplantation of bone marrow derived stem cells. And the third one is ovarian injection of platelet rich plasma. All of this, the evidence is accumulating, even though there is no unanimous agreement as to what are the absolute indications where we can expect an improvement. Many of the small published studies have shown improvement in the ovarian function as far as menstrual cycles are concerned with all the three therapies. And also sporadically live births have been reported. So this is a space to watch for. And as far as bone marrow derived stem cells are concerned, we must within the country know that there are regulations and special ethics approval are required before they are used for any therapy, and all these are considered experimental at present. Future perspectives, one of the important is particularly in young women with unexpected poor response. That is Poseidon group 1, where the ovarian reserve markers are normal, but yet they respond poorly to conventional stimulation. Percentage of them could be having various polymorphism. There is a large population-based study going on at present within the country, and hopefully over the next 3 years, it might shed some light on, sorry, not the population-based, it's a clinic-based study, multi-center study going on at present, which might shed light on the presence of various hormonal receptor polymorphisms and their contribution to unexpected poor response. Even though, you know, I've put this as future perspectives, it's already happening that fertility preservation with ovarian tissue cryopreservation or oocyte cryopreservation as a social, what we call a social ovarian, social oocyte cryopreservation is happening, but where medically indication is there, when there are certain autoimmune disorders or where suitable partner is not available and we have already diagnosed reduced ovarian reserve in an individual. These are those who are going through surgery for ovarian endometrioma, where an adverse impact on ovarian reserve is expected. These are the scenarios where we might be offering ovarian tissue cryopreservation or oocyte cryopreservation electively and as a standard therapy in forthcoming future. One of the interesting areas is, again, you know, this is more, these studies are more often conducted in the context of fertility preservation in young cancer survivors or those who are going through cancer therapy and prior to gonadotoxic chemotherapy, use of recombinant AMH to regulate follicular recruitment and prevent follicular exhaustion. And this is another interesting area. However, clinically, this has not been utilized so far. What is very important and what we can do at present is good reproductive counseling based on the based on whether they have infertility or they wish to defer pregnancy. The two important markers we would rely on are AMH and AFC. AMH definitely very important now that international harmonization is happening because of the or fully automated assays being available. Counsel them to fast track treatment or in certain situations consider oocyte or ovarian tissue banking. And maybe it will become part just the same way as we assess the ovarian reserve through various hormonal assays. It might become part of the assessment to look at receptor polymorphism so that they don't go through a futile cycle before the very first cycle of IVF. So these are all in the pipeline. So these are the spaces to watch for. So I think, you know, this presentation highlights how big a conundrum it is to treat women with poor ovarian response. The cost of the treatment, the emotional stress, the social stress, the social stigma they go through. And at the end of this, all this road, they're still likely to have lower success rate compared to their counterparts, particularly below 40 years of age, where their counterparts are more likely to have a better success rate in IVF than those who are diagnosed with poor ovarian reserve. So what is very important that it is increasingly becoming a common clinical program with far-reaching emotional, social, and financial implications. Indian women, Indian ethnicity again has an impact, and infertile Indian women have an earlier onset of reduced ovarian reserve This has been very well established now compared to the Caucasian counterparts. It is very important that they should aim for an early pregnancy. What they should do depends on the age factors, while younger ones can still go through a short period of simple forms of treatment. It is extremely important that each one of them is provided appropriate reproductive counseling, and we should aim for evidence-based treatment and avoid protracted courses of futile treatment and simple ovulation induction. Early diagnosis and prompt treatment strategies may reduce the need for egg donation in this subgroup, particularly when they are young. And as far as stimulation strategies are concerned, both antagonist and agonist protocols with high starting dose of FSH or highly purified HMG are most frequently used, and highly purified HMG might be considered as a good source of LH activity, particularly in older women with reduced ovarian reserve. Mild stimulation, when they have gone through a conventional stimulation and they've had a very poor response, mild stimulation could be as effective as a conventional protocol. But if you look at the cumulative success rate between the two, we must emphasize that a conventional protocol tends to reduce the time to pregnancy because it's less likely to have cancellation. Role of dual stimulation needs evaluation before being incorporated into routine practice. Thank you.
Professor, Madam is this was.
Yes, thank you, ma'am. You have wonderfully covered all the aspects of POR or POF. And it's really a burning problem for all of us. I think at least, Monica, 50% of our cycles now has almost become poor ovarian reserve. It's a very high number. Very few young patients come up in spite of all this awareness about age, that every time we counsel the patient, the age is the most important factor. Age is, well, those who marry late for the career purposes, other things you can't blame them. But those who just wait and wait after marriage for 10 years, 15 years in treatments which are wasteful and expensive as well without IVF, they end up in poor ovarian reserve, and then they come to us. That becomes a very burning problem. Not ready to for donor eggs, or donors are also, as I said, becoming in shortage. So the best way out, I suppose, is the awareness about the fertility potential. We cannot push them into marrying early or having pregnancy early, but at least if they know, they can preserve their oocytes, or if they already have a partner, they can preserve their embryos and then use it later after their career is over.
You're right, sir.
Thank you. Thank you, madam, for very wonderful covering all the aspects.
You're very right, sir. This is a this is a problem which is going to increase, multiply, because now we are seeing just I think the tip of the iceberg, the patients who are walking into fertility clinic. There must be such a huge load of poor responders everywhere. And I also advise patients, after a first child, they give a gap of too long, Sometimes they want a second child after 6 years, 8 years. It is better in the current scenario if they are having the first child after the age of 32, 33. It is better to complete the family before they are 36, 37, the watershed line. Thank you so much for chairing the session, Professor. Always your comments are very welcome, very encouraging. Thank you, Anurag,
Thank you for
joining us.
giving me this opportunity. This was a wonderful seminar of all the important topics covered very well.
Your pleasure is all mine. And yes, Anu, please.
I forgot, Dr. Monica, you are also going for this chairperson perinatal committee. I wish you all the best. And I request all the Foxy presidents or state chapters or their district chapters to, and the secretaries to vote for you, because you are very knowledgeable, very well deserving. And also Dr. Sneha, who is very well deserving, and wish you all the success and may you win. And I am waiting for you all to come to South ISAR, which is starting on Friday, and we will share more academics here. Thank you so much.
Thank you. Thank you for the invitation, Dr. Anu. I'm really looking forward to my Bangalore trip. where I will enjoy some nice 36 hours with all of you. Thank you so much. Thank you, Professor. Thank you, Anu. Thank
Best,
you,
best
Sahiti.
wishes, Monica. Best
Thank you, sir. Thank you. Thank you. Thank you, Sahiti. Thank you, Shield Connect. And we'll see you in the next benchmark. Good night.